Hello, everyone. This is Michael Saltzman from Blue Sky Bio. I hope everyone is staying safe and staying healthy during these times. We are continuing with our viral dental education webinar series, presenting a webinar almost every day at 1 p.m. Eastern Time. So please follow our schedule, stay up to date. The webinar schedule is listed on blueskyplan.com/webinars 2020, as well as on the Blue Sky Bio user group and the Viral Dental Education Facebook group as well. There's also access to the past recorded webinars, so if you did miss those, you could watch the recording, take a short 10-question multiple choice test, submit that, and we are able to send you a CE credit. A couple of technical issues regarding the webinar. CE credits will be sent within around 2 weeks via email after the webinar. So please be patient and look out for those. Webinars are recorded and made public after the webinar. So if you do miss one, you could go back and listen to the recording, complete the quiz, and again, get that CE credit. If you have any questions during the webinar presentation, please enter them into the questions and answer QA box. That's the QA box and not the chat box, so we could address them during the webinar presentation. Today's presentation is being given by Dr. Robert Mickley. This is the second of a 3-part series. Again, the first part is recorded and available. The topic of today's webinar presentation is atraumatic extraction and bone grafting. Dr. Robert Mickley practices in Brooklyn, New York. He's a recognized expert on implantology and lectures extensively. He also runs an in-office mentorship program for general dentists, providing hands-on instruction regarding implant surgery. Robert?
Hello, welcome back, everybody. Can you see me, Michael?
Yep, we could see you, and you could take the screen share back as well.
Okay, great. And let's share our lecture. Okay, great. Welcome back, everybody. So nice to have everybody back. Okay, so we're going to be continuing what we were talking about last time. If you missed last time, it's up, I believe, on the certainly on the Blue Sky website. And is it on YouTube as well, Michael?
Yep, it's on YouTube as well.
Okay, great. So you can find it in either place. So you can go back and we covered atraumatic extraction extensively last time. We covered a lot of the biological basis of all of wound healing. Really, that's the basis of anything we're doing to the jawbone, the alveolus, when we're doing implants or doing extractions or grafting. It's all based on the biological basis of wound healing. So go back and take a look at that, because a lot of the questions that I get asked most commonly when teaching are based on those. So if you have a solid understanding, those answers become clear to yourself before even asking it. So yeah, definitely go back and take a look. So today we're going to be focusing on mostly bone grafting. But we'll review briefly. We talked about the coronavirus. Obviously, we're in a state right now. Don't panic. You're here. You're using your time wisely. Just build as much of the practice as you can when not physically in it. I know most of us struggle with how much we work in our practice versus how much we work on our practice. So now we don't have a chance to work in our practice, so we get a lot of time to work on our practice. So being here is working on the skill set, but just make sure that you're constantly building. So when the days that we're back in practice are there, we're refreshed and we're hitting the ground running with new skill sets and with a whole new refreshed outlook. Again, we're always going to want a day or two back like this soon. We don't want them now. We have too many in a row, but we will want those days back where we just have things to focus on, bigger picture things in our business. So take advantage of that as much as you can now. We said last time, the economy will be slow for a little while on the recovery, hopefully just a little while. So we're going to have to do a lot more with less. So that's what we're here for. We're going to learn to do a lot of these things in-house that we maybe have been sending out before, and just have a better knowledge of how things are working to be able to even market to our patients better of the advantages of slowing things down, doing dentistry a little bit slower, and doing, let's say, a atraumatic extraction and leaving bone intact rather than a traditional extraction where bone is oftentimes damaged. The bone grafting as well, and then getting into implants as being the next step. We said keep calm, wash your hands, use lots of Purell, and stay safe for now, and we should be back pretty soon. And again, we said last time, in the midst of every great crisis lies a great opportunity, so just continue to take advantage of that time. I try and wake up every day and having a lot of family time, which is fantastic, but try and put a couple of hours away every day to move forward in both things personal and professional that I've always wanted to do, but just didn't have time for it. We talked also a little bit last time about Lab Pronto as being a great way to be able to, we're talking about flattening the curve for the virus. This is kind of jumping the curve, where the learning curve for anything that we're learning new, those who participated in Corey Glenn's lecture, learning how to fabricate guides in-house, and if you saw, the lecture was supposed to be 1 hour and it went 3. Corey is a fantastic lecturer, and it was great, but I think for the novice, you see it's a ton of information. And if you're dedicated to doing it and you want to spend your time doing it, you will get there. But don't feel that it's so daunting that if I don't have hours and days and months and years to dedicate to getting good at the software and at fabricating guides, that I can't do it. The answer is, if you can get a CT scan and you can get either a PVS impression that we can digitize, or take an STL file of their jaw with an intraoral scan, you can get a guide made. And you don't have to know really anything about the process. But again, the more you know, the better. You can send it all out via Lab Pronto. You click on order a guide, and that'll send you over to the site. The clinical treatment plan only, or you can do the surgical guide fabrication, or you can have the clinical treatment plan and surgical guide. Again, as much as you want to do in-house, you'll do, and you can save money, or if your time is more valuable, then you want to outsource everything and use the service more. But again, as dentists, we're always calculating our chair time and our value of our own time. So when we're really busy, which we want to be, you want to outsource as much as possible, because you want to use your time seeing as many patients as you can, because you're the only one who can see patients. But when things are slower, that doesn't mean that your time is not valuable. It's maybe a little bit less valuable, but it's still quite valuable. Take the time, learn how to do these guides so you can do them yourself, and maybe just export out the printing. And then when you get busy again and you don't have time for that, that's fine. That's when you'll start exporting out the full plan. And again, Lab Pronto is a great service. The kind of the way it works and the thought process behind it was kind of what we do in dental learning now, where we're crowd sharing and just sharing information amongst each other and using the benefits of everyone getting together. So what they've done with Lab Pronto is they have different labs who are available for your given case. And when your case gets uploaded, it can either get sent directly to the lab of your choice, or it can get sent to any lab who has time now. And that's why it's called Lab Pronto, is because they'll get it done for you very quickly. Because if one lab is full and doesn't have time to see your case for a few days, another lab may have an opening and gets your case today. So you can upload it, have it sent over to whoever you so choose, or just get it to the fastest person possible, and they'll get it done for you. Again, so this is part 2. We're going to talk about socket preservation and guided bud regeneration. For those who don't know me, just a quick review. I went to Stony Brook out in New York for dental school. I did a GPR at New York Presbyterian Hospital of Queens. I did a fellowship in oral maxillofacial surgery there as well, where we did the prosthetics and the surgery. My private practice is limited to surgery, but I do a heavy amount of temporaries. So what I do in my practice is I do the surgery, I do the prosthetic plan with the dentist or without them. It is by their choosing. Some just trust me and just say, just do whatever you do well, and we know it'll be great. I appreciate it, but I love when people want to be involved in the process, and we do the prosthetic workup together. And only then will I go ahead with the surgical plan, because everything that we're doing nowadays, as you've been learning, is going to be crown down planning. You're planning the prosthesis first. Only once you have the prosthetic plan can you then plan where those implants are. We're hopefully way past the olden days of implantology, where you got your implant patient back from the surgeon and it's in a non-restorable position, and you call them and say, hey, what happened here? And they say, that's where the bone was. Hopefully surgeons are much more educated on the prosthetics as well today. So if you're getting back implants that are not in ideal prosthetic locations, that's usually the impetus for many people to get training to do it themselves, because they realize in straightforward cases, you can place that implant knowing where the prosthetic's going to be, just as well as a surgeon, as long as you have the proper training. I also do out in the New York area, where we send out a surgeon, my associate and a few other doctors will send out to different offices to place implants for them in their offices, just to keep things, again, in-house for the GPs. And I have my mentorship program where we give you the training from, again, the very basics. You can have no background whatsoever, or those who have already good background but just want to go forward. We offer, different levels of training. We do sinus grafting, all-on-4 procedures, whatever you can imagine in implant dentistry, we're here to train you in. And what we're now doing, and I'm thinking as soon as this coronavirus is past us and we're doing elective procedures in our office again, I'm going to be offering virtual chairside coaching. So that's going to be as a similar format to what we're doing now. You will see me on either a mobile device or on the screen of your operatory, whatever you prefer. You can have a Bluetooth speaker in your ear, same as your regular cell phone. And you'll have the pre-op planning is done in advance. So it can be done anywhere in the world. You'll send in advance the CT scans, photos, STL files of the patient's mouth, and we'll talk about all the details in a separate series, how to get all that information. We work it up in advance so you really know what you're doing prior to the surgery, as well as you would if we were there in person. We'll fabricate your surgical guide together. We'll have it printed either here, like literally here, or we can have it emailed to a local lab to you so it can be delivered even faster. We'll do a web conference, again, Bluetooth speaker in your ear so you can hear me and speak to me during the entire procedure. And again, you can take your skill set to the next level. In all of our training, when we were, let's say, simply in dental school and we're doing our first filling, you do a step and you're not sure what to do next because it's your first time. So you go to the instructor and you wait in line. If it was like we did in Stony Brook, the instructor comes over and says, okay, proceed, it looks good. Or change something, it looks a little bit off, and improve things. And that's how you learn to take it one step at a time. Sometimes the courses that you're just going to and coming back to your office, you're learning information and it's great, but then when you get to your patient, it's a little different than what you learned, because every patient's a little different and every situation's a little different. So how do you manage that? So that's what we try and do, is we try and get live in real time. Your questions are answered right away, and just that feeling of you've got the over the shoulder coach helping you out to just take the next step. So from simple to more advanced cases, we'll work all that up, and hopefully we'll launch this as soon as the virus is over. Okay, so into grafting. So what is a graft? So a graft itself is when you're taking different biological structures and kind of forming them together. That will allow us to have a new entity, which then can be usable. So this is nothing new in the world of biology. It's done in trees oftentimes. Say the tangerine, for example, and is a graft of 2 different tree branches that can give us a new product out of it. So grafting is taking 2 different biological entities and allowing those 2 biologies to merge together. Graft material properties. So there's a lot of details of grafts. There's a lot of different products out there. I'm going to give you the ideas of what questions to ask to decide what product is best for you. I think hopefully the more educated doctors don't just take marketing from reps who want to sell you a lot of their product and say it's the best product in the world, and they'll show you they're showing non-independent studies how they're the best. What we've found is, and we're going to go through some of the literature, but what we found in the literature is that they all work really well. That's the good thing. We'll talk about what the advantages of some are versus the others, but they all work really well. Understanding what you need for your given situation is what's really important. So here are the 3 basic breakdowns. So we have osteogenic, osteoinductive, and osteoconductive. So what do those terms mean? So the osteogenic grafts are the grafts that possess themselves the cells that can create new bone. So the only bone that really does that is autogenous vital bone. Hypothetically, you could have a donor graft that's still alive do that also, but I don't think that's really done very often anymore, if ever. But it was done for a while. But nowadays, really, autogenous vital bone is your osteogenic, that's your gold standard graft. And I say gold standard only in the sense of the biological healing process, but not necessarily the best for every kind of graft. The downside to the autogenous grafts is they have a higher shrinkage rate. So you need a lot more graft to be able to hold on to an area than, let's say, a different graft we'll talk about in a little bit. So they're good in a lot of places, but not in every situation. Their biggest drawback is, again, the shrinkage factor that will significantly be less volume of bone there at the end than you put in the beginning. But it is osteoconductive in the sense that it has live cells that will recreate in the same area. Osteoinduction is when you have a molecule in the graft that stimulates the neighboring cells within the host to be able to put new bone into the area. Those recipient sites will stimulate them to differentiate into osteoblasts, as we talked about last time. And again, if you weren't here last time, a quick review is you have two basic bone cells that we're really thinking about the whole time, is osteoblasts, the ones that cause bone growth, and osteoclasts are the ones that remodel the bone around it in order for the osteoblast to work. And these are some of the different proteins that are used and growth factors that are used to stimulate bone surrounding the area into healing faster and or better. And theoretically, it promotes faster integration of bone. But these materials have been out for quite a while. What I do is in my practice, I'll use them when I have a very large graft and I just need to give it, kind of throw everything that we can at it to let it heal as best as possible. But it's in the very large grafts that I'll use some of these. But your bread and butter, your everyday cases, it's total overkill. What's more important is to keep the four walls around the socket in good shape. That will be better than any of these other materials. I use them for onlay grafts and things like that, where they're just helpful. But again, I've done many with, I've done many without. I see slightly better results with, but again, I think that's in terms of your hierarchy of what's important in a graft, it's really towards the bottom. It's a nice little help, but it's toward the bottom, and they're quite expensive. So for the novice, certainly nothing even to think about. Know that they exist, but don't think it's going to take a badly placed graft into a badly preserved area and just make magic happen. That's certainly not going to work. And osteoconduction, that's our bread and butter, where we're mostly going to be working. So osteoconduction is creating a scaffolding of bone for those new bone cells to latch onto. And again, those osteoblasts will come in from the margins of the existing bone and start to grow on that new framework that we've laid down. And that's really where most of our help is. So types of grafts here within those categories, we have autografts, allografts, xenografts, and alloplastic grafts. And we'll talk about those in some detail. So autografts. Autografts are the containing vital osteoblasts. It's, again, a donor's site within the same patient. So you're taking from elsewhere in the jaw, elsewhere in the body, and you're grafting to that same patient. That's, again, it contains the vital osteoblasts and has no risk of rejection from within the patient. It's free. We say that in the sense of financial freedom, but not in the sense of, there's nothing is really free in this world. It requires a second surgical site. So although it's free in terms of cost, it will cost you extra time to harvest that graft, and it will cost the patient in terms of morbidity for a second healing site. The earliest we were doing this in dentistry, we would work with our orthopedic colleagues, and they would harvest the graft from the hip. Or otherwise in dentistry, we would harvest graft from the symphysis, or most commonly, I would say, we would harvest from the ascending ramus and take a chunk of bone from there. And again, this is an area where there's an abundance of bone. There's no vital structures if done properly. You have your inferior nerve and your long buccal nerve in this area, but as long as your incision is done properly, it's your least chance of getting into trouble in this area. And I would say nowadays, when I take bone, it's usually the ascending ramus, sometimes the tuberosity as well, but the ascending ramus is probably most common. But again, even within these, it's still less common to me than other grafts, because as great as these are, the increased morbidity and increased chair time, again, are not really free in the real sense. And the fact that it's the quote unquote gold standard because it has osteoblasts within it is, again, in terms of the hierarchy of grafting, still not in the top of the list. If anyone would like to raise their hand and take a guess where this graft is coming from, I'd be impressed. Have any hands being raised? I don't see the questions, Michael. If he's anyone jumping in where this is from?
Yeah, we have some calivarium, the scalp.
Excellent. Beautiful. Okay, that's exactly where it is. So this is taken from the scalp. There is a fair amount of bone in the skull, as we know. It would not be my go-to place to go get it. If you are not dual trained in general surgery and dentistry, I would not advise this at all. But again, it's just bone from elsewhere in the body that can be grafted. And again, this was this surgeon. He was a dual boarded MD and DDS, and he thought this was just the easiest and most intuitive place to take bone from. And be able to graft it into place, and securing it with lag screws. And again, it'll work because you have an abundance of bone there, but it wouldn't be certainly my go-to area. Talk about more things that are much more common for us to use in the general dentistry setting. So within the allograft class, again, the allografts are the grafts from a human donor. That's, again, it was once upon a time belonged to a human being. It's then been processed to the point where there's no DNA left, and there's two different ways to process it. And you're going to see reps will offer you two different things, and you'll look at them and say, what's the difference? And the reps usually don't give you a good answer. They'll say, well, one's freeze dried and one's and not demineralized, and one is demineralized and then freeze dried. And say, what does that do? Exactly, because the research hasn't panned out a big difference. When they were going through processes to be able to sterilize this bone and be able to use it for grafting procedures, there's two different ways that were kind of thought of to do this. One was to demineralize them, and one was not to. The biggest difference is demineralized bone, when you take an x-ray of it, won't show up in an x-ray. When you take a mineralized bone graft, it will show up in an x-ray very clearly. So I always prefer to use mineralized, but some prefer demineralized because they want to see when it does mineralize later, when the graft heals, they want to see that healing on the x-ray. They don't want to take an x-ray afterwards, say 3, 6 months, whatever, down the line, and still see the graft. They want to see newly grown bone, and I understand that. But to me, I really want to see my post-op graft and see how that progresses, rather than seeing a black hole and then seeing that get mineralized over time. But again, they both work well. It's just a matter of preference. And again, the study showed no significant difference between the two materials, primarily intraosseous defects, when evaluated at a minimum of 6 months post-surgery. So they both, again, work the same. It's just really the biggest practical difference is showing up in an x-ray right away. Risk. So when you're dealing with any kind of a human graft and you propose this to your patients, and I always mention to my patient the different places we can get grafts from, the first thing is, they say, well, is there a risk of contamination? And again, they're definitely not going to get coronavirus from it, but can they get any other bloodborne diseases, any other viruses, anything else can be living on this? So there's been no reported disease transmission in the 30-year, now probably 40-year history of using freeze-dried bone allografts, but there were 4 cases of HIV transmission when using fresh frozen bone allografts. Again, not in the dental field. This was in the general orthopedic field. So they would have let's say a donor on life support, a human donor on life support. They would take the graft prior to the patient expiring. They were brain dead, but they have not fully expired. Freeze that bone and then transfer that over to another patient. Back then, the way they were testing for HIV is they were testing for the actual virus. Nowadays, they were testing for the antibody of the virus. Right? We've all become a little bit better in our immunology since having to learn about corona. We dusted off some of those books. So what we do is they were testing for the virus itself. And as we know, the virus itself, the antibody of the virus. They're testing for the antibody because it would take some time for the body to produce the antibody. And then they would see that and know that the patient was HIV positive. Nowadays, they test for the actual virus, because what would happen is in the early stages of a virus contraction, the patient, now as we know very well, can be asymptomatic, but have a very high viral load as this virus is growing, until the body starts to produce antibodies, if it is able to. And the area of coronavirus, it's still very early and difficult for the body to do because it's a brand new human virus. And HIV at the early stages was as well. And when they were testing for the antibody, the patient was at its highest viral load. Let's say they would get into a car accident. They were testing for the virus, the antibody. I'll make the mistake a few more times. Testing for the antibody, didn't see it. Patients at a very high viral load, and they would give either blood or otherwise transmission to others. And that's how you had a very high level of HIV transmission in, let's say, the 80s and probably early 90s. Nowadays, they're testing for the actual virus, so it's very, very rare for that to happen. But again, back to bone grafting, it's a non-issue. This is totally sterilized bone, and there's no DNA left. There's no way to trace this back to the donor other than the fact that it's written on the bottle by an ID number, which you keep track of in your chart just for proper charting. But there's no DNA left. I tell them it's once upon a time belonged to a human being, but no longer, and no chance of any transmission of any kind. This is a famous baseball picture. Anyone also wants to jump in if they can guess this bloody sock. Any takers? We got baseball fans out there. Now we have no sports to follow. Anyone?
Kurt Schilling.
Very good. Kurt Schilling's bloody sock. So they did a procedure in the infamous 2004 ALCS where he had some ligament tear in his ankle, and they repaired it with some sort of cadaver bone to help support things. I'm not sure the exact details of it, but the sock is sitting in Cooperstown, and that is a famous graft that was done. But again, what is the real concern? The real concern for our patients is they think we get our bone like this. Someone is digging up bodies and just making bone graft that way. I used to say that this was never the case, but there was a oral surgeon in New Jersey. I don't know if anyone has heard about this. I forgot his name exactly. It was a very unique and interesting name. But he actually started a bone graft company, and he was digging up bodies in New Jersey. And I don't know how companies weren't asking him, like, hey, where are you getting this bone from? But they didn't. And this went on for years. He made millions and millions of dollars of selling raw bone material until he was caught. And yeah, sitting in jail somewhere now. But so this did happen at some point. But if you're buying from a reputable company, this will never happen again. In the United States, I know there's only two bone banks that create bone, where other companies will buy it from them and repackage it. So when you're getting allografts from other places, it's basically coming from two places in the United States. I assume in Europe, it's probably very similar. I assume in Asia, it's very similar as well. There's a couple of bone banks that are harvesting the bone from donors, processing it, and then selling that to companies for their own labeling.
Robert, there's a question that came in, if I could jump in.
Yeah, please.
Any differences in handling technique considerations between DFDBA and FDBA? Packetability.
No, so when you look at the materials, you won't really see a difference. One's demineralized, and it really only shows up in an X-ray. So handling properties are the same. I one time had an order in my office placed. I usually get the mineralized, and it was accidentally sent as demineralized. And I took a post-op X-ray, and that's when I was like, I know I put a graft in there, but it's not showing up. That was the first time I noticed it, but I put the graft in, I never even noticed the difference. So handling properties are identical.
Okay, and what about the beta-tri calcium phosphate success rate? You have any information?
Excellent. We're gonna get to beta TCP in a little bit, but beta TCP is a synthetic graft, so we'll get to that in a little bit. Just another concern, if anyone could guess this t-shirt also. It's got two well-known origins. Any guesses?
Let's give them a minute.
One is slightly more famous than the other.
Star Trek.
Very good. Mr. Spock. Good. So Mr. Spock used this hand sign, but Mr. Spock got this from a not well-known tribe within the Jewish religion, where they're known as the priests. And the priests within the religion cannot come into contact with dead bodies. So this is important to know. Also within Islam, as Mr. Spock, within Islam, they also have different rules of being in touch with corpses. So you never want to let your patient know that after the fact. I actually had a patient once came to my office in a panic and said, someone put a dead body in me. You must remove it immediately because I have a contamination now. And I talked him down. I said, listen, talk to your religious advisor about this, but medically, there's no issue here whatsoever. But you don't want to cause a panic after the fact and tell them after the fact that you put in cadaver bone. So let them know what it is. They'll be a little bit grossed out by it. That's fine. But I just tell them it's the most like our own body, and it's my go-to graft in most cases. Because I see that the hard tissue healing is what I found is to be the best. And for some reason, the soft tissue healing is also better. I don't have a good reason why. I've just seen that in my experience. I see the soft tissue on allografts is best. But again, it's also the most expensive by a significant margin. So you got to see in each individual situation where it makes most sense. But the properties are the most like natural bone when you come back. And usually that's a good thing, but not always. Sometimes I want something else. That takes us to our next graft, which is the xenografts. Xenografts is bovine bone that is also processed and can be used in a graft material also. Microscopically, it'll look a little bit different, but practically it doesn't look much different. They all look like kind of like something like a fine gravel or sand material, a little bit more coarse than sand, a little bit finer than a fine gravel, but somewhere in between. So this is BioOS, which is the most common xenograft on the market. And what they're showing on their histology is look at all these osteoclasts and new bone, mineralized bone forming around our BioOS particle, which is great. But when you have autogenous bone or you're using allografts, what you find in histology about a year or two later is that you only have native bone. When you go back and do histology on these patients, probably for decades, you're still going to see BioOS particles there. The BioOS particles are not live bone. So your overall blood supply and everything else in the bone is not as native as it would have been with another material. That in many cases, to me, is a negative, but in some cases, it's a positive. So first of all, just in my hands, when I drill back into a jawbone that has been grafted with BioOS, the bone feels too hard. Meaning, again, it's not the same sort of feel as a natural mandible. It's got a little bit more density to it, a little bit harder. And again, by definition, that blood supply will be somewhat affected. Again, is there a clinical difference between it? Probably not, but it's a little bit harder, which I prefer it not to be. Where I do like this to be is in sinus grafts. In sinus grafts, I'm asking the bone to build back up in a completely hollow environment. I create kind of a bubble of graft underneath the sinus, and I want that to stay there very stable. So in those cases, autogenous bone, which has a higher shrinkage factor, is probably one of the worst ones because it will tend to shrink down. The next level up would be your allograft, which again is good, but it has some shrinkage effect and is not quite as hard. And with sinus grafting, the posterior maxilla is soft bone to begin with. So if I'm going to have even slightly softer bone of a graft, that's a negative. A xenograft in this area would be very advantageous because it's going to give you more stability and the bone will be harder. I'd much rather have harder bone in the posterior maxilla than the native type 4 soft bone that's already there. So in those cases, it's a really good material for that reason. When you're looking for extra stability Or when I'm doing an onlay graft, I'll oftentimes do a first layer of either autogenous or allograft, and then layer on top of that a xenograft on top of that, and then I'll place my membrane, which we'll get into next, on top of that, and then maybe PRF or anything else otherwise around that. And just to preempt some of the questions I know will be coming in about sinus grafting and PRF, in a sinus grafting lecture I'll get more into it, but oftentimes you can do sinus grafting with just PRF if you're placing the implants at the same time. The reason is, again, stability. If you place the implant at the same time, you create that bubble underneath the sinus, and you just put PRF, what's going to happen is the PRF is just mushy gel material, so it's going to flatten out pretty quickly. You'll get some growth, but you won't get a tremendous amount of growth. So if you need a lot of bone growth for that implant, it's not your best material to use. But if you're placing your implant at the same time, you create that bubble, you place the PRF around it, and then you place your implant to hold up that sinus membrane. That will work well. And I do that quite a bit. So I tend to move away from xenografts if I'm placing my implants at the same time. And I was saying in the overwhelming majority of cases, I'm placing the implants at the same time, unless there is 1 or less millimeters of bone there, and I can't stabilize that implant over the course of healing. Even if I stabilize it on day 1, again, we talked about the osteoclasts start working first. So if I only have 1 millimeter of bone and the osteoclasts are working, it's got nothing else to hold on to, my implant could get dislodged and fall into the sinus, which is no fun. We'll get into that in the sinus grafting lectures, which we don't have scheduled yet, but we'll get it on there. And we'll go into that in greater detail. But again, stability, xenografts equals stability, and sometimes that's a good thing, sometimes it's not as great, but either way, it works well. Another type of xenograft. What's that?
Can I jump in with some questions?
Yeah, please.
Okay, what company do you order your bone and membrane from?
Excellent. So I've changed over time. It really, at this point, because the banks are the same and they're just packaging it differently, I personally will get the largest kind of cortical cancellous allograft that I can. Some companies sell them in 2 cc's, some sell them in 5 cc's. The packaging a lot of times is what is the greater cost. If your office goes to graft fast enough, it makes sense to go through a 5 cc. Fast enough, and you know that your staff is keeping sterile enough that you can open a package and not let that get contaminated. In my office, what we'll do is we'll open up a package in a sterile area away from the surgical field, take what we need for that grafting procedure, and then bring it into the surgical field. If your office is just doing kind of spot grafting here and there, it makes more sense to get a small package and get like a quarter or a half cc at a time, because if you open a 5 cc's and it gets contaminated, you've lost a lot there. So my personal go-to is the largest bottle will sell me from the company that will, again, a reputable company that I know and I trust, that will get it out there at the most reasonable price. The ones that I use the most are in New York. I'm getting Carl Schumacher is excellent, and Ace Surgical. Both of those are fantastic for allografts. But again, I would use really any company that is, obviously has FDA approval and is not coming from a cemetery in New Jersey, that is processed properly. Those will work well.
Okay, so connected to that is, if there are only 2 U.S. bone banks, is there any reason to favor one bank or one private labeling over another? Or is any of the allograft in the U.S. imported, or just from these 2 sources?
So to my knowledge, it's just from those 2 sources. I could be wrong. If someone knows differently, please either post a comment or shoot me an email. But to my knowledge, and speaking to companies, they'll tell me, yeah, we're just getting it from anyone. I think it's Tissue Bank at the University of Miami is one, and I think it's called Rocky Mountain Bone Bank somewhere out in, I would guess, Colorado. That's the other one. Those are the 2 main banks in the U.S. If anyone knows, again, differently, if anything's changed over the last couple of years that I'm unaware of, please let me know. But to my knowledge, that's the best. And again, they're processing it basically the same. I haven't seen any difference between any of those other materials. Certainly, I haven't seen a paper showing any advantage one over the other at all. So the answer to the question is no advantage one over the other. And in Europe, again, I assume it's this same process going on for all of these, and they're basically the same by the time it gets to your office.
Okay, can you comment on when you choose cortical versus cancellous particles?
Yeah, so I personally like the cortical cancellous mix. So what's going on is we have two layers of bone. We have the cortex of the bone we talked about last time. That's the outside firm part of the bone. And there's the bone marrow cancellous part, which is softer bone in the inside. If you're just using cancellous, I find it's too soft. If you're just using cortical, I find it's too hard. So most places do a 50-50 mix, and I find that works the best. You kind of get the best of both materials.
Okay, is there any reason, regulatory or otherwise, to not use one graft container for multiple patients?
So again, it's all about sterility. So I use one container for multiple patients on a sterile field, meaning I'm not bringing it out for that to that area that's anywhere other than anything sterile. So I'll have one jar on a sterile area in the operatory. It's on a sterile drape. It's covered with a sterile drape. The drape is then, when I know how much graft material I'm going to need, I'll say, can you get me 1 cc of Allografts cortical cancellous? Good. I'll have an assistant. Usually it's a second assistant who's just a floater back and forth between rooms. We'll come in and take with a sterile syringe, and I'll talk about that in a little bit, how I transfer it, load it into the syringe, and then we'll hand it over to the chairside assistant, who will then hand it to me to use for the graft. So I use one larger bottle, but it's transferred over on a sterile area. I can't emphasize that enough. If your office, and again, everyone knows their own office, if your office is not doing a lot of surgery and tends to be a little bit sloppy, it's not an insult. I just mean that to be that you have not everything is as sterile as it could be. Don't use this method, because again, as we know, virus we're all thinking about now, and sterility is being the utmost importance. Don't take any chances. If you can't be sure that your staff, and it's not even you a lot of times, you're training your staff to do this. If they're not going to follow this out properly, don't bother doing this. Get smaller packages, pay a little bit more, because if something gets cross-contaminated, you got to throw the whole thing out, obviously.
Okay, great. There's a comment that came in that they will love a course on sinus grafting, particularly with the new Blue Sky Bio fully guided sinus lift kit. So we'll get that set up.
Yeah, we'll get that scheduled next week or so. Absolutely.
Okay, let's take one more.
The outpouring of lecturers has really been very inspiring, because a lot of the really top people who and I think what you're seeing now is that people who love to teach, and yeah, people make livings from teaching, but when times like this and no one's working, and if you love to make a living, you're saying to yourself right now, you don't want to teach anybody because they're not paying you. But if you love to teach and you're sitting at home and that's what you do, So you're teaching for free. So now is the time to grab it, because you're having people just giving away, multi-$1,000 a piece courses for free online. So grab the opportunity.
Yeah, we're definitely very appreciative of all of our contributors, educators. Let's take one more question before proceeding, and that is, what do you think about bone graft and implant placement in heavy smokers or in patients who are on bisphosphonates? Did I pronounce
Bisphosphonates, yes. So we talked about bisphosphonates a little last time. Just a quick review. Bisphosphonates will slow down the osteoclast activity. So your entire healing process will be slower or will come to a screeching halt. Generally in oral bisphosphonates, it's a slower, but it could be a screeching halt. So bisphosphonates is a risk factor. We'll talk about a little bit more about it when we talk about patient selection in the next section, part 3. So we'll leave that as a hold, and smoking as well. It's a risk factor. We'll talk about in part 3 into greater detail.
Okay, there are more questions, but let's proceed for now, and we can continue with.
Good. Okay, so another type of xenograft. So this is taken from, again, a different species and used. So this is not bone material. This is actually collagen material, but it is a little bit different than just a collagen plug. What this is a heat-treated collagen, and the way that it's heat-treated, and I didn't believe it until I really used it, is that it's heat-treated and it slows down the process in which it degrades significantly. And again, our goal here is to create a scaffolding around the blood clot for the clot to be able to hold on to and new bone to be able to form on top of. So although bone is much more stable, and bone material is much more stable, this collagen material will stay there for about 6 weeks until it fully degrades. So that's a lot of time for the body to be able to start to have those new osteoblasts forming. Once they're there, the graft is really unimportant anymore. And again, we hope at our 1 to 2 year process where the graft has completely been dissolved by the body and it's all new bone, new native bone in the area. So this is a great material because it's first of all, it's super user friendly, and it really works. I use this in two sort of cases. I'll use it in cases where the bone is so bad that I have really no high expectation of getting much in the first round of grafting. So what it'll do is it'll just give me a solid clot so things start to form again. That's one area. Another area is where I have pretty good bone everywhere else, but I'd like it to be stronger. Again, this is a better material to use than just a collagen plug. Easier to handle than bone, less expensive than bone most of the time, but still significantly more expensive than collagen, than regular collagen plug. So if you're looking to graft but don't want to get involved in particles just because of the need for a little bit of more skill for it, and you want to just get into something easy and quick, this is a great material to use. It's made by, what is the company? We'll see in a second. Morbida, I believe, is the company that manufactures it. But it's a really good material. I think if you're doing some grafting, it's a good thing just to have in the office. And again, another idea, we showed a case using the foundation last time. What you'll find is the handling properties, there's two sizes, it's small and medium. Small is about the size of a premolar socket. The medium is like the size of a socket and a half of a molar. It looks way too big to fit in there. What you do is you need to wet it with some of the patient's blood. So you want to make sure that socket has some good bleeding to it. Also has good hemostatic properties. So when you pack it into the socket, you're going to see the bleeding is going to slow down very quickly. So you want to make sure there's an abundance of blood in the area first. You want to wet it and kind of pump it into the socket a couple of times to soak up the blood and then place it inside. What you don't want to do is place it in there very quickly. Then the outside layer has blood on it, but the inside layer has no blood. If there's no blood, it's not going to be effective at all. So you want to make sure that it kind of soaks up some of the blood. Sometimes in some cases where the socket is just not bleeding well at all, even when I take a burr and try and decorticate the outside layers to get some extra bleeding, I just am not getting enough blood flow. I'll make a couple of small superficial incisions in the soft tissue just to get a little bit extra bleeding to cause saturate this graft with some blood. So this material specifically needs a good amount of blood to be saturated with it for it to work well. Just some theory here of some other xenografts. There are talks of using wood materials and different kind of 3D printed materials. Wood would be a xenograft because it's a living species, but 3D printed materials is more of a synthetic graft, but it's just a hold of scaffolding. We'll talk about that concept in a little bit as well. But this is what it would look like microscopically. And again, as long as it has an area where blood cells can form and then can dissolve the graft itself, it could have some meaningful use to it in the future. Okay, so now we're getting to the alloplasts, which are the synthetic grafts. So the two major ones on the market and oftentimes are put together is hydroxyapatite and beta-tricalcium phosphate. The Cerazorb material is one of the first ones that I use. There's a few others on the market, but it's basically all beta-tricalcium phosphate with or without hydroxyapatite. Hydroxyapatite is there to try and stimulate bone to grow into the area, to try and attract bone to the area. I'm not aware of any papers showing the hydroxyapatite making a clinical difference, but I could be wrong in that as well. If anyone has any papers and knows of anything, please, again, post it, email me, or both. I'd love to see that because I do use this material still some as well. Certainly when someone does not want to use a human material, and I do have that request sometimes, even though they'll say, yeah, doc, I get it. You telling me it's not going to do any harm of any kind, but I think it might, and I don't like it. I don't like the concept. Then in those cases, it may make sense. Sorry about the lighting. I just realized my lighting in the background was off. Okay, hopefully that's a little bit better. Yeah, so synthetic material will work really, really well. I just find that the overall healing of the soft tissue is not quite as good as when I'm using an allograft. But again, it's still a good material to use, and significantly less expensive than an allograft. Okay, so that takes us through the different types of grafts. If you have any questions on that, it'll be a good time to just field any more questions on graft material types.
Okay. Any concern of amount of saliva getting in the socket site and graft material during the grafting process?
So the answer is sure. We'd love it to be as sterile as possible, but again, we're working in the mouth. So I wouldn't take blood and mix it into I wouldn't take spit and mix it into my graft material, but it's going to get in there. We're not creating a waterproof seal here. We want to happen is the blood clot to be the overwhelming majority of what's there, and let it naturally seal itself off. But you want to minimize the amount of saliva that's in there as much as you can, but you can't obsess about it. Like, I'm not putting a rubber dam around the socket so that we can put the graft in, because once the rubber dam comes off, it's going to saturate saliva anyway.
Okay, what is the name of the alloplast you use?
Of the allograft material is, again, it's either the two that I use the most in my office are Ace Surgical and Carl Schumacher. Those are the two companies I'm using the most.
Okay. Do you use sticky bone to mix with the graft?
Yeah, so I didn't get into PRF here because it's kind of like its own animal. And the early stages of your career, those who are just getting involved in grafting, it's like a next level thing. But to go out and buy a centrifuge and start to draw blood, it's nice. It's very helpful, and I use it a lot. But it's again, there's no studies showing any clinical advantage to it. But it has a lot of handling properties that can add to it. And overall, there's some studies about less post-op morbidity in some cases. So it has some advantages to it. But again, there has been no studies showing a significant difference. So I don't get into it a lot here. When I do advanced grafting courses, I talk about it because it's very helpful, specifically with soft tissue. But if you're dealing with sockets, I use it, but if you're starting off, it's overkill.
What do you do with the unused bone graft in order to re-sterilize and reutilize it for another case?
Out, chuck it. Once it's on your surgical field with your first patient, it's done. Once you've hydrated it to use for a patient, it can't be used again for another patient. So I always think I'm being careful to not use more material than I need. And then I always finish and I have more material than I need. So I try and estimate as much as I can to get it right. Better to take a little bit less and just add to it than to take too much. And like I tell my kids about the cereal in the morning, don't fill up your whole bowl. You're only going to take a few pieces. Yeah, once you hydrate it and it comes onto the field with everything else, with a non-sterile instrument, it's done.
Is foundation built as a membrane or a graft?
Graft. Not a membrane specific. We're going to get into membranes now, and you're going to see why that's the case. What's the difference between them?
What is your protocol, and what material do you prefer in vertical augmentations? Okay,
so vertical augmentations is, I guess, a step above this. We can potentially do an advanced grafting course. With this, would be the principle and the next level up. But vertical augmentation is one of the more difficult things to predictably do because everything needs a blood supply. So if you have walls around it that will support it, you have a 4-wall defect, which is really a 5-wall defect because you have the 4 walls on the sides and you also have the bottom of the socket to perfuse the area with blood, that will heal very, very predictably. You're missing 1 wall, you still have 3 others that will still perfuse it with blood. You're missing 2 walls, you still have 2 others that will perfuse it with blood. But now you have what we would call, if 4 is our most, you have a no-wall defect, which you just have the floor basically, and you're decorticating that and trying to get that to perfuse your grafts with blood, but that is not easy for the body to do. To get enough oxygen up into that graft to heal properly is not easy. So it's upgrafting. It's some of the least predictable grafts. In terms of certainly just vertical is difficult. So like in the posterior maxilla or mandible is probably the most common place where we want to achieve it. You need to build something up with a thick and strong membrane to be able to support and not move at all. We'll talk about movement in a little bit. And you can get some grafting to work. You also need to get a full closure well over it. So it's in a very advanced procedure. Again, if you're early on, just again, send those out for now. And to someone who does a lot of them that will do it well. And there's some people who are great at getting their predictable numbers up there higher. But again, you're fighting against biology here to get it to work. You're trying to push it as much as it can to favor our direction, but inherently you're at a disadvantage.
Okay, let's take one more question before proceeding. Several dentists are asking regarding putty allograft.
Yes.
Putty type grafting material in a syringe versus dry material.
Good. Great questions. So we talked about it a little bit last time. We'll review putties again. So putties, what they do is it's a dissolvable gelatinous material that handles very well. But again, the companies know that their biggest cost is the bone itself. The gelatinous material that they're putting in there is very inexpensive. So they're going to try and skimp you on that as much as possible. And if you take a post-op X-ray, you'll see there's very little actual bone in there. It's mostly this gelatinous material, which is not very helpful. It dissolves very quickly. It's just like a collagen plug itself. So if you have a solid 4-wall defect and you just want this as an extra added little bonus, sure, it's helpful. But based on how much bone they're actually putting in there will be how much more helpful it is than just a collagen plug. So it's not a go-to material for me. It's very easy to handle. So I will say that. If you like the handleability of it and you don't need a lot of bone into the area because you have a solid 4-wall defect or a good 3-wall defect in a membrane, then go ahead, use it. It's a good material. But it's certainly not a go-to material because you just have less of the actual bone in there. And regarding a preloaded syringe versus a non-preloaded syringe, just dry material, so that's just, again, ease of convenience. So for me, I've trained my assistants to load up these syringes, which I'll talk about in a little bit, quickly and easily. So the fact that it's in a syringe, again, if that will add to the speed of your procedure and makes your life easier, it's a convenience factor. But to load it up yourself is not overly challenging to me. So to me, it doesn't justify the cost of having the companies load it into a syringe for me. But it's very convenient.
Okay, let's proceed with the lecture, and then we'll take more questions.
Oh wow, we're already pushing an hour. We'll try and hurry things up for those who only have themselves an hour. But again, those who don't, I think we stayed 2 hours last time. I think Corey stayed for 3 hours last time. Michael doesn't mind working overtime, so we'll keep going. Okay, so barrier membranes. So what are we trying to do with a membrane? So again, I think what certainly people early on who I train in implantology want things to be pixie dust, that you sprinkle it on and it's all going to heal. So just realize the basic principles always apply. So what is it doing? What is a membrane doing? Does it need to be put on every socket? I get asked that question all the time. So I'll answer it with another question. What do you need to stop from entering your socket? So if you need to stop something, then great, use a membrane. If you don't need to stop anything from entering the socket, then a membrane is just a waste of time and money. If you need epithelium to not infiltrate your graft, then absolutely you're going to need a membrane. But if you don't, then the membrane is superfluous. As we said, soft tissue heals at 1 millimeter a day, while bone heals about 1 millimeter a month. So if you allow the two to race, and you have a 3-wall defect where let's say the buccal plate is the most common one that's missing, then the soft tissue will infiltrate your graft and it will not heal well all around. You'll get some healing, but based on the size of that dehiscence will be how much deficiency your graft will have. It was originally come up with for periosurgery. The idea was you have a perio defect with deep pockets. You went in and scaled everything out. That's great. And now you have a healthy environment for things to heal. But if you don't differentiate between bone and soft tissue will infiltrate that same pocket and you will be not much better off. You've removed the bacteria, but bone will not regenerate. So the concept was, let me put a barrier of some kind to stop the soft tissue from growing into that site. If that's the case, I'll get bone to regrow. So if you see what looks like spider webs on the bottom of here, you can see my mouse, down here, this is bone starting to regrow. If I did not have this white barrier membrane in the way, the gum tissue would just reestablish itself along the bone on the inside. So that was the concept of how it came up with. And that's how it was first used, and that's how research was first done on it. Then they had different ideas of what materials to use. During the early days of anything, a lot of people are going to try things new until we come up with some kind of a standard. So the two basic kinds were the non-resorbable Teflon type of materials versus the resorbable materials that are used. We'll talk about them a little bit and properties of each. So the non-resorbables is basically EPTFE. The most important thing early on is that it required primary closure. And this was difficult to achieve. So if you, in some areas where you don't have good either quality or quantity of tissue, and you had a dehiscence in the soft tissue, these would get infected very quickly and had to be removed. So they were highly susceptible to infection. They had to be removed 4 to 6 weeks afterwards, otherwise they would tend to get infected. But when done well, they had excellent results. Gore-Tex was the company that was manufacturing this most. Again, it was tacked down. It would oftentimes have, well, you see this metallic material inside of here is just a titanium reinforcement to it to give it some extra body to create that bubble inside of the bone where the soft tissue would grow over. And it worked. And tacks are used in these cases a lot of times to hold everything in. And when it's really stable, it works really, really well. But it was discontinued back in 2011 because people were realizing that the resorbable materials were working very well also, and they kind of fell out of favor. Periodontists and neurosurgeons who liked them kind of bought out the last materials that they had then because they really preferred its handling properties over the resorbables, which are a little bit harder to handle. But the downside of a second surgery, I think, just was enough to knock it out of the market. There are still some non-resorbables out there on the market, but they're few and far between. The same EPTFE material is used in air conditioning filters and all sorts of filtration. And I just Googled this, GE's using this. I don't think they're charging, $250 for a 20 by 40 piece of it, millimeters. We do tend to get charged on the up end in dentistry, somewhat because to go through FDA approval is very expensive. I get that. But yeah, we do get gouged a little bit by the market. That's just what it is. I put zirconia down in here because I think this may be, to me, sounds extremely promising in the future of customized non-resorbable membranes for long-term large grafts. And we talked about vertical grafting. I haven't yet to do one. I had one scheduled 2 weeks ago, but that got canceled by Corona. Hopefully we'll be doing it soon, and I'll have some clinical photographs to show for it. But zirconia in general is known for its excellent soft tissue responses. So soft tissue crowns, zirconia crowns and frameworks on the soft tissue react very, very well. It does not, because it's so smooth, bacteria does not adhere to it well at all. And we tend to not see that kind of red inflammatory response when these things sit against soft tissue. So the soft tissue properties are excellent for zirconia. That's well known. I haven't yet placed any zirconia implants myself, but I know those who do. One of the biggest factors of why they like to place them is because of the soft tissue around the implants. When we get into the implant section, we'll talk about how I don't believe that the implants should ever be in contact with soft tissue. But that being said, when zirconia is in contact with soft tissue, it has a very, very favorable response. It can be secured with lag screws for excellent stability. So the zirconia itself obviously has no mobility whatsoever. It's very, very firm. It's like an exoskeleton, and is then secured with lag screws, which will have zero movement. So when that's done, I think this could be a really, really promising material to use for larger grafts. And Corey Glenn has a great video on a case he just was working on. Again, I don't think it was done yet, but he designed a zirconia membrane for somebody. And you see here, basically, it was just overlaid in mesh mixer over the CT scan of the patient. You have to segment out this to turn into its own STL file, export it to a software which can then create the membrane. But you can customize it to how thick you want it to be, how much bone advancement you want to happen, and then where those lag screws are going to go exactly. And hopefully I'll have some cases soon to show on doing this. But that seems really promising. If you can have a customized piece to place inside of there, where I just remove whatever is being removed, decorticate the bone, place whatever kind of material inside of there. And it could be something as simple as PRF, because again, the stability here is just holding the blood clot and the soft tissue forming on top of it. It seems very, very promising in the future. So hopefully we'll have some cases to discuss at some time in the near future. But let's talk about the bread and butter, our resorbable membranes. So our resorbable membranes are collagen type 1 or type 2. They're oftentimes made from bovine or porcine. I see bovine being the most common. Again, porcine, within the Islam religion, porcine, and again, if any of my religious statements are made obviously as a dental professional, not as a spiritual guidance. But if anyone has anything to comment just in their practices of their patient base being any difference, but I believe any pig material within Islam is frowned upon, at least. So be sure that you inform your patient of exactly what you're putting inside of them before you do it. It's then resorbed by enzymes or hydrolysis, and it can take 4 to 40 weeks depending on the type of material, and also has excellent results. Synthetic synthetic membranes also dissolve well, also have excellent results. The idea is it's separating out the epithelial cells from the bone. When you do that, you're going to have good healing within that. And when there was a study done all the way back in 1998 showing no statistical difference between resorbable and non-resorbables, that kind of set the tone for the industry to move almost completely into resorbables. Again, the only time I will still use non-resorbables and when I need the handleability of something to hold a large amount of graft over a large area for a lot of time. Then I don't want it to dissolve. I want it to stay there and be very firm. That's when I use something non-resorbable. And this is one of the most important points. If you learn nothing else from this lecture, you remember nothing else, remember this: the graft must stay stable. This is the death wish of most grafts. If something is moving on it or around it, as little as 10 microns, what happens is, and just moving back into yesterday, our biological basis, those mesenchymal cells we talked about, they differentiate into 2 kinds of cells, either into fibroblasts or osteoblasts. Fibroblasts are scar tissue. Osteoblast is bone. So when you get these fibrously encapsulated implants or you get fibrously encapsulated grafts, what happened at a biological level? Well, you had some kind of movement, some kind of micro movement that allowed the body to sense this is foreign, and it differentiated those stem cells into fibroblasts rather than osteoblasts. If you get that, your implant has failed and your graft has failed because it's been encapsulated by soft tissue. So that graft must stay stable. That is the most important thing for the graft. And one of the biggest killers that I found to stability of a socket preservation or of an onlay graft is a flipper. So a flipper is not very stable, as we all know, and that's why they are called flippers. They will kind of hang on to the other teeth, but if they're putting pressure onto the socket from the side, and every time the patient bites down, it's pushing into the socket, that the whole graft will start to move, or sometimes just the top layers will start to move, and that will be encapsulated by fibroblasts rather than osteoblasts. So just be really careful to make sure there's no movement on your graft. What I'll do oftentimes is I will rather do a fixed temporary, certainly anterior, than doing a flipper, because I can't control the stability of it, or I'll put rests into the teeth if I need to, that I know has a direct stop onto the tooth, or instruct the patient just to remove it when they're eating. But even that is difficult because just when they're talking, your teeth are constantly touching each other, so it's going to constantly cause that movement. So whenever I can, I'm not saying you can never use a flipper, but I'm just saying make sure you take the intaglio and really make it a concavity rather than a convexity. I mean, you're looking to hollow it out rather than have it be bulbous and push into the area. Labs, what I find, love to take your model, and if it's a stone model, they'll cut like divots into it, and then they'll make the flipper on top of that. But that will leave an indentation into your soft tissue and can start to move your graft. So before you put that flipper in, look at it, seat it, and if you see it's pushing on the soft tissue, you see that tissue blanching, it's kind of turning white, that means it's putting pressure on it, and go back and cut out the inside of that. But when you can, I'll take something like this, which is a Maryland bridge. This is a temporary Maryland bridge. It's an acrylic tooth, and I don't like to prep the teeth if I can avoid it. So I make these little holes inside of the metal wings and etch the lingual of the other teeth. Again, when there's room for this to happen, if there's enough clearance, and I'll etch the tooth, seat it with some flowable composite, and cure it onto there. So it's more of a mechanical lock than anything else. And when I need to take it off, because let's say after the extraction, if I haven't placed the immediate implant, I'm going to come back to implant it later, I'm going to have to remove this, so I can just take a hemostat and just kind of snap it off. The composite will break cleanly, do my procedure, and then it'll seat right back into where it was, bond it one more time, and we're good to go. Patients tend to like something fixed a lot better than something removable anyway. Do we always need to graft? This is one of the most common questions that I'm asked. So it all depends on your plates of bone around it, buccal plate being the most common, but really it's any one of the 4 walls surrounding the defect. Nevin's talked about the benefits of placing a graft. He showed that there was a 79% of cases had less than 20% bone loss when grafting was done. And this was, he was talking about 4-wall defects. Without grafting, 71% had greater than 20% bone loss. So again, significant advantages to leaving a graft in there. But I like to break it down into a couple of different cases. And this is found in the literature as well. When you have defects where the walls of the bone are 1 millimeter or greater, that means the bone is relatively thick. You have an option of doing nothing, meaning grafting is great, but lots of extractions have been done historically without grafting. And we don't see these giant gouged out areas of bone when no grafting is done. We know that grafting the bone will eventually heal. It just won't heal in the same dimensions we initially wanted it to. So the bone will start here, and without grafting will end up here. There's still bone there, but it's just less of it. But the thicker the bone, those walls of the bone are, the less that resorption will happen. So if you have 1 millimeter or greater of bone, meaning it's relatively thick bone, then you have the option of doing nothing. You'll have some loss of bone, but if the defect's big enough, does that really matter that much? So again, to me it does, because even though I'll have enough bone for the implant with some resorption, I want that to mimic as much of that socket of the initial architecture of that patient's jaw as it was before. So even though you can get an implant in and get a crown on it and everything be great, when you go back and look at the soft tissue around it, it will kind of have a sunken in look to it. So you have the option of doing nothing. And again, it's all about what a patient wants to invest in this. And I have a conversation with them about bone grafting. And if they tell me they don't want it, I just will show them 2 pictures, which I should probably put in this lecture. I did not, apologize. But of where you could just imagine soft tissue being ideal, where you can't really tell that an implant was done, versus being somewhat sunken in, which again, does that clinically make a difference? Sometimes yes, sometimes no, but I don't want to find out after the crown is done that it kind of did make a difference. So again, my practice is kind of specialized in implants, so we're going to make it ideal every single time. And you can encourage your patients to do that, but sometimes they'll say no. And sometimes you'll tell them, well, then we're not going to be able to place an implant here. That's fine. Or you could tell them you got a pretty good shot at it, but the gums might be shrunken in after the fact. So just, again, explain to the patients what's going on. But do you need to? So in 1 millimeter or greater, you don't need to. You can put a collar plug. It helps create some scaffolding, but it'll just be dissolved faster than everything else is healing. And you'll get some loss of bone, but not enough to not be able to get an implant in. But the soft tissue will oftentimes suffer because of it. Less than 1 millimeter of bone with no dehiscence. So then you're putting a graft, a collar plug, or something just to hold the graft material in on top. You can put a PRF plug. You can put anything you want on top of it. But what you don't want to do is you do not, under any circumstances, want to get primary closure. And let me explain why that is. When you have a socket that's open and you have no primary closure, what's going to happen is epithelium needs its connective tissue underneath it to be able to start to form. So when you look at a socket, why does it form just in the margins and start to collapse in? Because it can only form once the bone from the outside starts to have those early blood cells starting to form, which can then give you a periosteal layer underneath it for it to be able to grow on top of. Until that happens, it will not heal on top of. So that's why you don't get invagination of your sockets when you graft the socket. If you get primary closure, I know it sounds kind of counterintuitive. If you get primary closure, what's going to happen is it'll cause an anastomosis of the soft tissue on both sides. So now you have blood flow between the two sides, and you have soft tissue. And now what's going to happen? The soft tissue will start to grow down faster than the bone can form a periosteal layer up. So in those cases of a regular socket, and people's heads explode when I give these. I can't see your faces now, so I won't see it. But people get very confused by this. When you have a socket, you don't want primary closure unless you're putting a membrane. But that would necessitate you putting a membrane, which is unnecessary. So I tell people, just put something on top of it to keep your graft in place, put a couple sutures on top, and leave it be. That's plenty. But if you have a dehiscence, now you need a membrane. Now it's a different situation. And just to give you an example, just to help you remember this principle. So anytime you get a cut on your body, we all know, it starts to itch a little bit as the scab heals. And we scratch on it a little bit and probably scratch it a little bit more than we should have. And we peel it off and it's still bleeding on the inside. You ever wonder why the margins are healed and the center is still bleeding? Why doesn't the whole thing heal flat across? What is this happening? What is this healing from the margin? So it's the same idea. Epithelium, same as we have on the outside of our body, still needs the connective tissue underneath it to be healed to be able to close up. That will happen from the margins in. It won't happen from the bottom up. It happens from the margins in. So same idea. If you peel that off too early and you get bleeding on the inside, that's because epithelium hasn't had a chance to close it up yet. You can remove the borders of it, but if you remove that center piece before it's ready, you'll get bleeding. So same as a socket. Socket will heal from the sides in, but if you get primary closure and cover it up, then it could start to grow down. That makes sense. Okay, less than 1 millimeter, no dehiscence, so just no primary closure, but something to hold it in place. If you have a dehiscence, meaning you have a wall missing, so now you are going to need a membrane. That's going to be what we call guided bone regeneration. You're guiding the bone to regenerate over this area, not allowing the epithelium to close in. In America, if you're using some codes here, some codes that are oftentimes used for ridge preservation versus guided bone regeneration. I believe, and correct me if I'm wrong, I don't do any billing in my office, and we don't accept insurance as payment. We give them their paperwork. So I don't believe that the guided bone regeneration, I think that's included with the bone graft also. I don't think you can build two separate codes, but I'm sure someone listening to this knows this very well and can answer that question better for everybody. So if you could post it in the comments, I think everyone would appreciate that, just to be able to be 100% sure. But again, these are reimbursable by insurance companies in the States as well. Again, every plan is a little bit different, but it hypothetically would be reimbursable. Just to show you a couple of cases, as we're now, I apologize, 20 minutes overtime and winding down. And again, I'll stand for questions as long as people want to hang out. Case number 1 here, again, we can see radiographically that we have bone loss already here. All the way down, say halfway about down the socket. So when I see an X-ray like this, I already have treatment planned the membrane. So I'm not, and I'll tell them exactly what the fees are. If I'm unsure, I will let them know that this is a possibility, and I'll give them a worst case scenario. In my experience, I hate telling patients during surgery, hey, this is worse than we thought, it's gonna cost you more money, is that okay? Because what the hell are they gonna tell you anyway? Like they're in the chair. I don't like to make a person feel that they're held hostage. I wanna tell them, this is the worst case scenario. This amount of money that we're charging for the membrane may or may not need to be done. We'll be thrilled if it's not done, but if it needs to be, you've been told about it. And that way, the fees seemed high. They realized they need it done. they're on board, and then they feel like they made money if you didn't need it. So you're a hero. If you did it the other way, and you didn't tell them about it, and now you have to charge them after the fact, you seem like you're just trying to upcharge them money, and they're leaving the office already in pain from the surgery and very unhappy that they are paying more money than they originally thought. Okay, good. And okay, so here's a case.
Right, wrote that 7953 and 4266 are billed separately by code description.
Good. Okay, so two separate codes. So if you're just doing a graft, it's 7953. But if you add a membrane, the second code is added, the 4266. Good. Thank you for that. Okay, so this is the case we showed last time as well. You remove the tooth atraumatically. You're left with some granulomatous, upset tissue. You want to clean all of that out very well. Again, I either use a spoon or a high speed. I tend to use both. I'll use a high speed carbide burr we showed last time. If you want to stay around the end and want to see what that is again, I'll go back and show that. But you want to clean out that socket really well. And this is, in terms of grafting, one of the most important points. If you're lazy with this part and you don't clean it out well, the healing will not be as well, will not heal as well or at all. Because again, soft tissue will continue to grow in that area and will not allow the bone to grow well. That's our diseased tooth that we've taken out. We then take, let's say in this case, there was because there was a buccal wall defect, we're using a membrane here. You can see one end has become a little bit bloodied as I tried it in. I cut it to shape, so like this butterfly shape to be able to fit into the area. The neck of it, which is the thinnest part, is where it'll fit between the teeth. So one side will tuck into the buccal side, one side will tuck into the palate side. Even though there's no dehiscence on the palate side, I'm just using that for stability. I'm going to tuck it under the graft, under the soft tissue, just so it stabilizes, and that will alleviate my need to use pins and tacks in most cases. But I want to make sure that this membrane will kind of over-cover the walls of the socket to make sure that it's full coverage and not allowing soft tissue to infiltrate in any direction. I'll place that inside. Again, one area is tucked in onto the buccal, one area is tucked into onto the palatal. And what I'll do is I'll first place the membrane, that's step one, onto the buccal. Make sure it's full as deep as it needs to go, either to the apex. Then I'll put my bone graft material in, because if you put your bone graft material in, it's much more difficult to fit your membrane in after the fact. So first put your membrane in, then put your graft in, then fold the membrane over onto the lingual side, tuck it in, and a couple of stitches on top of it. Here I just use a figure-8 stitcher. Nowadays I'm using probably 3 or 4 sutures across just to make sure that it's very secure and not moving anywhere. You'll always leave an extra layer on top of bone material that will kind of overfill. This is beta-trocalcium phosphate material used here. And I tell the patients some will kind of fall out on its own after the first couple of days, and you'll feel like these little pieces that feel like sand. I tell them it's okay, you can spit it out, you can swallow it, just try not to rinse your mouth out heavily because we don't want to dislodge this graft. But the more sutures you put in to secure it, the less chance they have of dislodging anyway. And then that flipper that we talked about, I just make sure to gouge out the inside, that I'm putting most of my weight of this graft, of the flipper, onto the palate. That's going to be my most secure wall, not onto the buccal and not onto the socket itself. Again, that's what it's going to look like from the side. I want it to, here there is, you can see some of that blanching in the tissue. So I want to make sure I would take that out again, cut it down more, and then seat it again. Once the soft tissue heals from the outside, I can come back and reline that flipper for a little bit more stability if I wanted to, but I really don't want to rely on the soft tissue as much as possible. And this is the bottom here of the graft. Looks like it's missing. What's there is kind of bunched off the bottom of the membrane. I then have bone material packed on top of this. I'm going above and beyond the crest of the bone, and I know that because the top layer is going to slough away anyway. I'd rather the top layer slough off after some healing, be above supracrestal than at the crest or lower, and then we're losing some bone height that way. Another case here is of this was a periapical pathology here. took out the tooth. I think we had a fracture in this case, I'm pretty sure. Yeah, down the furcation with a fracture here. Atraumatically removing each of the roots separately after sectioning them. Now we have a nice solid area to be able to graft into 3 separate 4-wall defects that will heal very, very well. In this case, if you see the sinus is kind of dropped down to this area, and our crest of bone is probably about there, so we have about this much bone to be able to do. Again, could an immediate implant be done in this area? Maybe. When it's taken out here, it actually would be. I would say nowadays I would more likely not do this immediate implant today if I have it guided in advance. This is a little bit an older case, so there's no guide involved. So just, again, minimizing your risks. I know people, when they're starting out, think about immediates right away. I tell people, again, slow down, do one thing at a time, and you'll be much, much happier. You'll be happy, your patient will be happy, and you'll have very predictable results. The more times you try and include multiple procedures in one, the greater chance you have things for just falling apart on you. So this is a good case to argue for an immediate, but unless you've done, again, 20 to 50 implants with advanced sinus grafting being very commonplace to you, I wouldn't advise it. Just take it easy. This is the bone carrier I was talking about, which you would take and fill up with bone, transfer it over to the mouth, and inject it in. And you want to do this kind of like you're building an amalgam. For those of you in the crowd who are younger than me, you may not even know what an amalgam is. Amalgam is these silver fillings that you may not have ever placed, but the way you would do it is you would place a base layer, pack it, place a little more, pack it more, place a little more, pack it more. The reason you do that is so the bottom layer is nice and solid. Same way as in a graft. If you pack the entire socket and then take an instrument and try and pack it in, the bottom will be very diffuse and you'll be left with very big spaces that have no graft material. What you gotta do is into each of those sockets, put a little bit of graft material, take an instrument and pack it in, come back with a syringe, push more material, pack it in probably 3 times is about average for a socket, and you've got a nice full solid fill. What you don't want to do is drop it on the floor, especially when I was using glass carriers. That's no good. I told my assistant when she dropped this, she felt very bad. I said, you know what, I'll put it in lectures and it'll stay on for all eternity, so you don't have to feel bad. It was a waste. But it was a waste. Anyway, what I do nowadays is we take plastic, disposable, or autoclavable. Some of them are autoclavable. Diabetic syringes, very inexpensive, very easy to work with. They could be made in different sizes. This is a 1 cc size. What you do is take a scissor, cut off the end. You don't need the needle part. Please dispose of that safely. And now you've got a hollow syringe. You pull back the plunger. You take a let's say a dapping dish that you can sterilize, that's autoclavable. Make sure that it's an autoclavable material, not one that will start smoking in your autoclave. I like the rubbery materials more than the glass ones. The reason is I can better manipulate when I'm packing this little syringe into a rubber dish. I'll get all the material into the syringe very easily. If I'm using a glass dish, I just don't have the malleability of the dish to let everything pack in. I always have some extra that gets wasted. But a glass dish will work. You'll just end up wasting a little bit more material. So take a diabetic syringe, pair of scissors, cut off the end, pull back the plunger, and pack the material. And that's how you have yourself a very inexpensive carrier that you can use that's much easier than just scooping. In residency, when I wasn't paying for bone material, we would scoop it and lose half the material in the patient's mouth. And I'm sure many of you have had the same experience. Use one of these, you end up not wasting any material, and it's much faster than scooping. Because scooping, you're getting a very tiny amount every time. This one, you're done 2 or 3 goes at it. Within less than 2 minutes, you've grafted the whole socket. And that's how you want your fill to look. Packed in very nicely. This is, again, beta TCP material. This is just a collar plug on top. And I could have done a much better job here. I like these old pictures because I want it to look a little bit sloppy so you can see what's going on underneath it. So when it's packed up really nicely, you can't see what's underneath. So here, this was left open. Again, this will clot and this will stay here. I just have a greater chance of some coming out here. I'd like the collagen to press further onto this side, put another suture in here, another suture in here, another suture here, and you're good to go. And that's what it would look like fully grafted. This is an anterior case. to show you here as we'll close up. This is again using the 360 degrees around. You could do this with a scalpel we talked about last time, or you could do this with a perio knife. Go all the way around, separate the soft tissue, take out the tooth, rotate it out, and or using those proximators we talked about last time to eject the tooth out. In this case, had some resorption, that's why it was being removed, and I was able to rotate this out without much difficulty. Then taking a carrier, packing in the material. It's a good idea to use some gauze as you're packing it in to wick out the excess moisture, and you can see exactly how much graft material you have in there. And that's what it should look like when it's packed in. Taking a little piece of collagen, you can cut off a small piece and pack it on top in a couple of sutures, and that's what it'll look like at our post-op. But you see here that the soft tissue around the neighboring tooth is different. This has got a flattened appearance already, where this has more of a bulbous appearance. Again, in the cases like this, nowadays in an aesthetic demand case, where it's a high smile line, I may also do a connective tissue graft. Oftentimes, these I'm doing as an immediate implant as well today. And in anteriors, it's a good thing to do, but again, very technique sensitive when you're getting started. So don't start on anterior teeth, because you can mess it up pretty bad. And we'll talk about that in our next section. But I would do also a connective tissue graft here to bulk out this tissue to mimic the look of a root. There's another case of a fractured number 8. This is actually a case done in residency. We laid flaps on these. I wouldn't do that nowadays because every time we talked about last time, you lay a flap, you're removing the periosteum from the bone, and that's 80% of the arterial blood supply to that bone. So I've basically choked up oxygen, and I'm necessarily going to get some resorption of that buccal plate. Tooth is removed, and then we will put, in this case, we have a buccal defect. In this case, probably due to a pretty rough extraction. We'll take full responsibility of that, and we will then graft it. Now, oftentimes it'll happen. It'll be our fault that we made the mistake. Again, this was residency. The charging wasn't in it. But if I ever feel that I could have done the procedure better, but I'm using a higher end material to cover up for my mistake, I'm not going to charge the patient for that. That's just me. Everyone obviously could do what they like. But then we'll size this membrane and kind of cut it to shape. And what I do nowadays is I will not take the actual membrane and cut it to shape, because I will use one large membrane and cut just the piece that I need for the given scenario. So I'll cut the piece that I need, and I'll cut it with the sterile paper backing that it comes with. And what I'll do then is I'll take the paper part and I'll seat that inside the socket, cut that to shape, and then use that as a template, and then take the collagen membrane and cut around it. The reason I do that is, as you know, as those who have used collagen membranes before, when they get wet, they become very floppy, kind of like spaghetti. And when that happens, the handleability is much more difficult. So I'd rather get the shape done with paper and then transfer it over to my membrane. That way, when I put the membrane in, it goes in once and it's in. Much easier to handle that way. Just make sure you know the difference between the paper and the collagen membrane. They look the same, but they feel very different. Just make sure you don't get them mixed up and suture paper in there. That won't be fun. You'll fit it to size. This again, I use this case still because I'm laying a flap here. Nowadays, I would not be laying a flap, and I'd be putting the membrane inside the socket. But in this case, once I had a flap raised, I could slide the membrane under the socket between the soft tissue and the hard tissue. But again, I'm removing periosteum and doing it that way. So unless I needed to build bulk already, I would not lay a flap. Here's again this is Nuos. They also have a line called Allografts that is more nowadays. I think Nuos was the demineralized and the Allografts is the mineralized. I believe that to be the case. Someone, if you know the material better than me, correct me if I'm wrong, because I'm using nowadays Allografts only. I haven't used Nuos in years. And then we will tuck it in the buccal back under the palatal and suture it closed. And again, once I use the membrane, I can get primary closure, no problem. But if I didn't use a membrane, we have the issue of the invagination, as we talked about before. And here the case was, I think we took the tooth here and just bonded it to the adjacent tooth. The patient had diastema to begin with already, so we just cut the end of the root off and bonded it to the tooth next door. That was it. Just one more case of a buccal plate resorption. Again, I see the defect you can see the fracture line faintly here, but I see the defect already before I ever took the tooth out, so I'm treatment planning a membrane already. And you can see again, you see a fistula, the buccal plate is destroyed. It's a given. So once you see that, it's if you see it just at the apex, it could be the buccal plate's intact except for a hole at the apex, which may or may not need a membrane, depending on the size of it. But if it's anything sizable, you're going to need a membrane. That's our tooth. We take out the tooth, and you see, and I tell the patient this right away. You see what the soft tissue looks like before we started. As soon as I take the tooth out, the bone is already missing. The only thing supporting that soft tissue is the tooth. When the tooth comes out, that's going to collapse right in. So the membrane's going to push out. I'm going to want a material that's going to be harder here to hold up. This actually would be a case where I would today put a layer of Xenograft on the outside to try and get that that layer as strong as possible. That's our dehiscence. That's from our outside. We'll clean up the socket. We'll tuck in our membrane. We'll add our graft material, and we'll put some sutures on top of it. That's what our graft will look like radiographically. Good. All right, so that is it for this evening. Thanks for hanging in there. Sorry for the hour and a half. Again, I think we have our 10-question multiple choice, very, very difficult test to take afterwards to get your CE. If you have any questions.
A 10-question multiple choice test, just to clarify, is for people who are not watching it live. If you've watched it live,
okay.
send you the CE within 2 weeks. For people who are watching the recording and want to get the CE post-fact, then they need to take the 10-question multiple choice test.
Okay.
Okay, we have tons of questions. Do you want to pull up the QA in your computer, or you want me to read them out to you?
Yeah, let's do that. Let's see here. Q&A, 65 questions. Here we go. And again, if don't take it personally. If there are stuff that I covered in a previous lecture, or the previous lecture, or in the next lecture, I'm going to just tell you which lecture it's in, and we'll get to it. Would you use PRF alone in sinus lifting, or with some xenograft or sticky bone? I think we talked about that during the lecture. So we'll dismiss that. If I understood well, you can reuse sterile graft material. What do you do with a bone graft material that you open but only use half, for example, so I can use it later? Again, if it's on a sterile field and no unsterile materials came into contact with it, both the carrier materials, anything else that's been non-sterile touches it, it's out. It gets thrown out. But if it's on a sterile field where you're separating it out, or I know some people will take that 5 cc bottle, and on a day there's no patients there, they'll on a sterile area, they'll separate into 5 different sterile containers and then bag those all separately. Again, if you want to do that, that's totally fine. It's just a matter of if your time is worth going back and forth. There's no official rules on these. We're treating our patients. We want to keep everything sterile. So we all know basics of how bacteria and viruses transfer. Keep things sterile and repackage in whatever you want it to be, and you can do it that way. But again, everyone know your own office. I think we talked about it a lot. Okay, good. Next, is there any other xenograft that is comparable to BioOS that we can use, because BioOS is very expensive? I agree, BioOS is very expensive. I don't use xenografts a lot, so I use BioOS when I need it, but I don't use it very frequently. So if someone knows of an alternative, please post it on the chat area so we can all benefit from that. But I don't know of another one myself, but I'm sure there are some out there. Okay, Yusin Song asks, I missed it. Which is your go-to graft material, allograft or xenograft? So allograft, we said. And if you're just going to choose one material to use, if I had to choose one material to use, I'll use allograft. And it can work in every case. So I'd say that for simplicity's sake, it's one thing that can work for every situation. But there are some advantages in xenograft sometimes, in synthetics sometimes, that we talked about before. Good. I was under the impression that demineralized bone had some osteoinductive properties, not that I'm aware of. Again, that study that showed there's zero clinical difference, I think, stands for that. So even if there was hypothetically some osteoinductive process properties, which I do not believe it is, then there's no clinical difference anyway. But again, I don't believe there is. What percentage of cortical concells do you recommend? I personally use the 50-50. I just find that it gives me the best of both worlds. But again, you'll see from different lecturers and different people just will tell you this is what I do, and there's not a lot of great research behind it, but it's just what I do. And again, if there's one way that worked better than others, there would be definitive papers showing that, and everyone would do that. The fact that it doesn't just shows you that all these different concoctions that we come up with all work pretty well. Have you had any issues with grafting with the oxygen plugs when patient had infection at time of extraction? So we talked about this last time. I'll just mention it briefly. When there is a current infection, it must all be removed. You cannot ever guarantee that you've removed anything microscopically, but you want to remove everything that you can physically, macroscopically, and put them on antibiotics to be able to kill anything that could be remaining. What's the best graft material for use in an immediate central incisor implant with a buccal dehiscence? So I just talked about that in the last case. I think we probably got to it already. Today I would probably use a membrane to push out the dehiscence as much as possible, knowing that I'm gonna get some shrinkage. I would probably put a layer of Xenograft on the outside layer, and then put some, and just pack that in, and then put some Allografts deeper inside. But that is, again, more difficult and technique sensitive. If you just use Allograft, you'll be just fine as well. Aram Hassan asks, I have seen some docs have amazing results with graft product called Ethos. What kind of sorcery is that? I don't know. I've never heard of it. I'd love to cut and paste this now. I can't do that for some reason. I want to look it up. Never heard of the material and what it is, what it does. But again, once you know the biology, as we talked about, don't let them sell you sorcery. It's science. If it has properties that show induction, that's great. Oftentimes those are not really much different. Everyone can show you a case where look what I grafted and look how well it came out. That doesn't mean anything, because you can use literally nothing and still have it come out. You can just have a piece of collagen in there and look how well that turned out. Yeah, how well does it turn out in thin bone cases and in general cases over long periods of time? That's much more important. So don't let people sell you sorcery. George Wang asks, what brand of Xenografts, what brand is the Xenograft collagen? I think it was Merida. It's called Foundation. That's what it's called. Just Google Foundation bone graft material and you'll find it. I know Henry Schein resells it, and many other companies will resell it. So it should be pretty easy to find. If you don't find it, shoot me an email. I'll put you in touch with someone who will be happy to sell it to you. Okay. Vilma asks, osteogenics is another. I guess that's another material. May have been answering the question for me. Okay, good. Thank you. If buccal wall missing, would you recommend foundation? Do you use membrane over? So yes, again, foundation is not a membrane. It will be gone in 6 weeks, and it does not have properties to keep the soft tissue out. So I would still put a membrane over it, but you could easily put it in the socket, saturate the blood, and still use a membrane over the osseous defect. Okay, good. Edgar asks, any thoughts on osteogen plug? I think we talked about that already. That's just more plug than osteo anything. How different is the collagen plug from the sponge used for hemostasis? Not much different. Those are, I think they work pretty similarly. It's just there to kind of create a clot and hold things there. So I use them over grafts all the time, and they work very nicely. Philip Jenkins asks, how can you expound on synthetic grafts a bit more? Yeah, so again, just on a biological basis, they create a scaffolding. We know they do that. They dissolve a little bit faster than the bone materials, than the actual bone materials, but they work really well. Like they actually do create a scaffolding. They dissolve and they leave us with native bone there afterwards. So they work well. Just doing this enough, what I've found is is the bone is, when you drill back into it to put an implant in, most like natural bone when I use an allograft. Does that mean that you should do it? No, that means that it's going to be a little different. Does that mean that it's clinically going to make a difference? Not necessarily. It's going to be a little different. If you're doing a posterior tooth and the quality of the soft tissue and the hard tissue really don't make that big a difference, the implant's going to go in and the bone's going to heal around it. And in 2 years, histologically, it should look exactly the same anyway. So then, no, there's no really need to use anything different. And if that's the material you like, go for it. Try them in different situations. See what's worth. They all work. But if it's, let's say, a high aesthetic demand anterior tooth, I would then go with the most predictable material possible. So I would say that. Good. Can you pre-med? Do you pre-med with antibiotics and Paradex? So when they have an infection, yes, absolutely. If the patient has a periapical lesion, they are going to be on antibiotics for 3 to 5 days beforehand, depending on the size of that lesion. The only time I will not do that is if they come in pain and I need to remove the tooth today, and I just don't have that luxury. But I'm always much better off having them antibiotics beforehand. I'm sure those of you know, I think maybe I've talked about it last time, when you take out a really badly infected tooth, the anesthesia is never quite as profound as we would like it to be. The reason generally is the mass of bacteria that's there releases a very strong acid. The anesthetic is a very strong base, and those neutralize each other and leave the patient without profound anesthesia. So I always want them to have as little amount of bacterial load as possible when I take out the tooth. Do you use any antibiotic powder in the graft? I personally don't. I know some people do. I used to have an attending who would put it into his into the cement for the crown, so that if there was any leaching of material, antibiotic would be there to kill any bacteria at the margins. Yeah, so these things all work nicely in theory, but again, if they showed any real clinical benefit, there would be papers written and we would all be doing it. So I don't personally, but I don't think there's a big downside to it, but always be sure that they are not allergic to what you are putting in their mouth. Joseph Yasser asks, is hydroxyapatite good for socket preservation? Yes, absolutely. We talked about that. Good. But yes, it is very good. Do you prescribe antibacterial rinse and antibiotic post-operative? So I do give post-operative antibiotics anytime I put something foreign into their body. That's my own personal preference. So I put an implant, I put in a graft, I give them an antibiotic. Does that make a difference? Necessarily. I know we're kind of in a battle with the CDC a little bit, not much of a battle, but just trying to come to an understanding of when is it appropriate to give antibiotics versus overkill. They're concerned about creating superbugs. We're concerned about our patient in front of us having the least chance of complications. So they would like us to use less antibiotics. We would like less infection. So there's no clear directive that we cannot do it. My personal feeling is my greatest responsibility is the patient in front of me. I'm not going to over-prescribe. And I put them on a 7-day dose of the antibiotic. And for the hypothetical risk to the general public is something there, but it's still, the CDC will still say themselves is hypothetical. They can't tell you that this is going to cause a superbug and you're going to create, God forbid, another pandemic. So yeah, I do give antibiotics post-op whenever something foreign is in their body. Can I use PRF as the sole means of augmentation and extraction socket with all walls intact? Let me read that again. Can I use PRF as a sole means of augmentation? So again, what are you going to gain with the PRF? Is it going to give you a scaffolding? Not really. It creates a bubble, right? It's going to be a lot of very good healing cells, but it's not going to give you any kind of real scaffolding. So it's a clot. It's a higher percentage of growth factors in that clot than a regular clot would have, but it's just a clot. So to me, it's not enough. I would mix that with bone material to give it sticky bone properties. The only time I will use PRF exclusively is when I'm doing a sinus graft and placing the implant at the same time. Then I'm putting the PRF in there itself, but people may or may not want to hear it, you don't even really need the PRF to hold open the space. The only reason I'm using the PRF is to create that bubble, because that's a gelatinous material that can kind of push under the sinus to raise it, and then the implants will keep it up. But if I could then go back and pull out that PRF, I would still get the same result. I just need a blood clot of some kind to stay there. So the PRF is not doing anything to cause any real grafting to happen. So I would say, no, it's not quite enough, or it's not much better than just leaving the socket empty. What protocol if dry socket develops after a graft? Great question. We talked about it last time that in doing this 10 years, I don't know that I've had one dry socket. When you have graft material that forms with a solid clot, which is sutured over, that clot is very unlikely to come out. And if it doesn't come out, you're not going to have dry socket. So it's really a rarity. When I was in dental school, this was talked about like, you have to know about dry sockets because they happen once a week. Again, in my experience, that is not the case at all. So again, if others have different experiences, I'd love to have a conversation about it and see what your protocols are for grafting and what we're doing differently. But again, the dry sockets are, I have the paste sitting in my office. That was literally there from the guy that I took over. I don't think it has some expiration date. I should probably check, because I think I used it once or twice the first year I was in practice, just because I felt like let's use this. Maybe it's a dry socket, but it's not. Good. Any recommendations about graft material mixing? I think we talked about that already. Stephen Lee. Hey, Stephen Lee, you're talking to Asher Gelman. Cross-talking on my chat. Thanks for that. Stephen and I went to dental school together. He's a good friend. Asher Gelman, I've never met in person, but I've heard great things about him, and I know his brother well. Okay, next. Aton Kama asks, what about bone appetite? It's a very well-marketed material now. What it basically is taking a plaster of Paris type material and it creates like a bone cement and is packed into the area. It will then dissolve and you're left with bone there. What it is a synthetic graft. That's exactly what it is. I've never used it myself, I'll say that. I know it's quite expensive, more expensive or as expensive as an allograft. So to me, it was not a cost savings to even think about trying it. I have those seen on some of their, I think it's called Ogma Bone is the company that uses it or that manufactures it. They show cases of large amounts of bone. When they show the CT slides though, like I don't see healthy bone there. I'm not less than convinced. When they show me a CT scan, it looks very, very dense and not a lot of blood supply through it. Their clinical photos that I've seen look impressive, but when they're put up against a CT scan when seeing inside of that, again, I don't know. I've never used it myself, so I can't really comment on how good it is. It seems to give a good volume of bone, but I just don't know what quality that bone is. So I will just leave it as I can't comment because I've never used it. I've seen it, but it has not been convincing enough for me to try it. What do you think of calcium sulfite Ogma graft? I think I just talked about that. I think it's the same thing that we're talking about now. Have a putty mix with particular bone. We talked about that. Just it's more putty than particular bone. Good. What syringes do you use for bone loading? I talked about that in the lecture. Diabetic syringe of your size of your choice. Yes, I agree. Let's go through the lecture, please. We did that. Good. Okay, what is the rate of exposure of EPTFE and how can we manage avoid exposure? So it's not so much of a rate of exposure as it is the dehiscence happens because the tissue is so soft and it's against a coarser material on the inside. That's kind of how it can dehiss. Like when I'll use sometimes a titanium mesh in a large grafting case, there's a high chance of dehiscence. And I tend nowadays not to use it unless the tissue type is a very thick biotype because it just in thin biotypes it has a much higher rate of dehiscence, and dehiscence are a mess. So I wouldn't say there's a rate of exposure with the EPTFE. It's more of just the rubbing of the tissue against it that can cause it to expose. David Diamond just stating his name. Hi, David. Can you talk about titanium mesh? Oh, we just did. With or without BMP2. So BMP2 is, again, one of those things I'll kind of throw at the bigger graft. So anytime I'm taking out a titanium mesh, I will generally take out a BMP sponge to throw in there because I want to just give it its best chance. But titanium meshes are much less predictable than, if I'm using a titanium mesh, it means I need a lot of volume, and that's, again, much less predictable than others. For vertical augmentation only, yes, I agree. Dr. Springs asks, any experience with resorbable osseous membranes cross-linked with ribose that can stand up to weeks of exposure? I don't know if it's, so it's resorbable. Again, once it's exposed to the lysosomes in the mouth, it will dissolve much, much faster, right? Like, so let's say if you use a membrane and you don't get primary closure over it, and it's resorbable membrane, that's fine. You don't need primary closure per se, but whatever's not primary closed will dissolve up right away. So if it's a socket that you leave the top of it open and you don't need it, that's fine. When I use the socket preservation, as you saw before, I don't get primary closures on those. Let's pull up that slide real quick. Can you still see my screen? Michael, you still see my screen?
Yeah, still see your screen.
Okay, good. Just slide down to one of these. Here we go, membrane. Are you seeing the question and answers also on top?
No.
No, good, okay. So you see a membrane here. I don't have primary closure. I have exposed membrane here. So that membrane will dissolve in a couple of days. The membrane that I need is the membrane that's tucked in on the buccal here. That will stay there for 6 months. So anything that's exposed will dissolve. It's resorbable. That's just the nature of it. If they're saying it'll stand up to weeks of exposure, again, I can't comment on the material because I don't know it. I'm sure you will send me a link to it and I'll check it out. Good. David Diamond asks again, what technique and materials would you use for vertical bone augmentation? I'm going to leave that for a future lecture. It's a very involved question. That again, doesn't have, I'll just tell you what I do. Everyone's going to do something different because not a lot of great stuff, but I will hopefully have some zirconia membrane things to show soon because the science is sound on that, making a lot of sense to work. Dr. Stephen Lee, my dear friend, asks, what happens when resorbable membranes resorbs too fast? Yeah, it sucks because it's not going to hold its place that we need it to do. That's where the closure makes a difference. So the better closure you have over the piece of material you need, the better chances of that material staying there for as long as it's advertised. So in a socket, I don't need it to primary closure, and I don't want to disrupt the soft tissue and advance the flap to close it all the way because that's painful and I'll end up pulling too much attached tissue away from where I need it to be. So I won't do that on a socket, but on a ridge where I need it to be, because I've got a large defect, then yes, I'll advance the flap over it and get primary closure, and then my material will not dissolve too fast. Dr. Brown asks, is there any issue with using resorbable membranes if you can not get primary closure? Will it break down quicker? As we just said, yes. How can you stabilize collagen membrane in a socket? So I think we talked about that during the lecture. Tuck it in on the buccal well, tuck it on the palate well, or on the lingual tissue, if it's in the mandible well, and so a few sutures, and that should stay pretty well. I will also say that I didn't talk about that here, but in the advanced grafting class, I talk about horizontal mattress sutures to make sure that when you move the cheek around on the patient, you want to make sure that this tissue around that graft is going to stay stable. So if you have a large graft and you've advanced the flap and you're suturing over that and you get great primary closure, but then you move the lip a little bit and you see that tissue going back and forth, that's going to be a big problem. So what I'll do it on those is I'll put a horizontal mattress suture, which again, I'm not going to get into details of how to do that. We'll talk about in the advanced grafting course. Horizontal mattress suture over it to be able to stabilize it, not just from a vertical closure, but also compression from the sides so that when the tissue moves, it will not move the graft nearly as much. If you look at my Facebook page also, I've got some links to some surgeries I've done. You can see those horizontal mattress sutures. I've done a bunch of those. Okay, Jason asks, what do you recommend in grafting use if the extraction of a tooth will not allow from primary closure of a membrane? So I think we talked about that. We don't want primary closure in a, if we're not using a membrane. If you're using a membrane, you can get it, but you don't need it. And again, just remember that example of your scab, that it's healing in front, epithelium is healing in from the borders, not from the bottom up. Dr. Wright asks, when augmenting edentulous sites, do patients continue to wear their dentures since any movement in the graft affects bone volume? Yeah, great question. This is a big problem. If the patient's going to wear their denture over this large augmentation, it's going to press on it, it's not going to heal. So if you have to gouge out the denture in the area where you grafted to make sure that it's not pressing directly on it. And I'm doing, if it happens, let's say a posterior mandible, I just tell them it's an either or. Like, you're not going to wear your RPD or your full denture for a while while this heals, because if you do, it's going to cause this to fail. So yeah, I would say that's the case. But again, this potential zirconia, I would love to try one of those, because they could wear something on top of it. I would still be concerned about the soft tissue rubbing against it for the soft tissue's sake, but the graft is basically like in a dome and wouldn't cause any movement at all. So it might be an answer to this problem. But otherwise, yes, it's a big problem with dentures. Okay, I have collagen membrane. They hold for 2 weeks. Can I use them without bone graft just to preserve soft tissue going in? So we talked about the soft tissue going in. It won't go in, even with a regular clot. Would it work without primary closure? So yes, the only thing that the collagen is holding for you is just to keep the clot there, have less of a chance of dry socket, and it just kind of holds something in the clot in the area for longer. So no dry socket and better socket healing. So that's what it's good for. Clearly grafting maintained bone volume, but there is, oh, Dr. Gelman, this is great. Asher, if you're there, can you wave hello if you're still there? Not still there. Okay. Clearly grafted material maintains bone volume, but is there any evidence that the quality of bone is better or worse than non-grafted socket left to heal by itself? Are implants successful in grafted sites as non-grafted sites? So I will say again, the Nevins article research showed that there is resorption of bone in most cases where you're not grafting, but that could still be plenty of good bone to graft into. I mean, to place an implant into, rather. So again, I'm still concerned about the details of the full architecture around that socket. So even though I'll have plenty of bone to put an implant into, I still want the soft tissue to be as robust as possible. So if I got some resorption of bone, that soft tissue will follow, and you'll see clearly, looking at their ridge, that there's a drop-off of where the root evidences are of the neighboring teeth versus this implant. And sometimes that makes no clinical difference, but sometimes that makes a significant clinical difference if they get food impactions against it. And they say, every time I eat, underneath the crown, you know, the soft tissue's here, and the crown comes up on top, and it's bulbous, but the tissue underneath it is skinny. It's still enough to hold on to the implant, but it'll be a concavity where food can kind of get pushed in there and just be a nuisance. So I would say you could probably still get away with not, and we've all placed implants into sockets, into bone that was not grafted. That patient had an extraction done years ago, and now you're putting in an implant. They never had grafting done, and it'll work, but will it be as good as it could have been? That's my question. So when I take out a tooth, I want it to be as good as it could have been to be. But again, that's a different standard I'm holding myself up to that may not necessarily have a clinical implication in every case. I'll say that. But great question. Vlad asks, what resorbable membrane can you put which can be left uncovered? Any. So any resorbable membrane can be left uncovered, but as we discussed, the uncovered part will dissolve. Disha asks, sorry, what is the difference between ridge preservation? I give two different codes. So again, ridge preservation is the graft material, the particles, or the foundation material, and the guided bone regeneration is the membrane. Gabor asks, 7953 is usually not covered by insurance. Only a few polys do cover. Membrane is usually covered since it's a perio code. Interesting. You're saying the bone is not covered, but the membrane is. That's interesting. Okay. So if you see that to be the case, you may be more inclined to use a membrane in your grafting just to be able to get some reimbursement on it, assuming that the reimbursement justifies the amount of material you're using. Mohammed asks, is it okay to leave the membrane exposed? Talked about that. Miriam Abudre asks, is putting the flipper enough to make the membrane not exposed? No, flipper is removable. Many membranes shouldn't be left exposed. Again, a resorbable membrane can be left exposed if the part exposed is what you don't need. I think we talked about that a lot. I'll just, those questions going forward, I'll skip over. I think we're hopefully clear on it. If we're not, hang around and ask again at the end, and we'll go over it again. Dr. Lehrfeld asks, do you place the membrane in between the buccal bone and the gingiva, or do you place it inside the socket? Excellent question. So again, if I'm not laying a flap, I'm putting it in the socket, and that's going to be most cases. But again, hierarchy of importance. Number one thing of importance, you need to have a super clean graft. So if you have a super clean socket, so if you have let's say a buccal dehiscence, and you're not sure if you really cleaned it out well, and I'll tell you, I changed this over the course of time as I was more sure of myself that I cleaned it out well. What I would do is, and I would suggest this to those getting started with this, is clean out the socket as well as you can without laying a flap. Then lay a flap, because two reasons. One, it's good experience to be able to lay flaps. It's critical for surgery, obviously, to be able to lay flaps. So you want to be comfortable doing it. So do it in non-aesthetic areas first, or in low smile line areas where even if you get some loss of tissue or bone, it still will work. You don't want to do that in a high smile line anterior case and then ruin the case by doing that. But in the posterior, clean it as best you can, lay a flap, big flap. Once you're laying a flap, it doesn't matter how big it is. Lay a big flap. Obviously, the base of the flap has to be wide, and the end of the flap is more narrow because your base is the blood supply. If you go the other way and the base is more narrow and the top is wider, the whole thing can necrose because you won't have enough blood flow in. So again, so it's the maxillary, a kind of a rhomboid shape. So you make the release and suture lines out, open that thing way up. Take a look at your socket and see how good a job you did, because you can't really tell that well by visualization through the socket that you can see once you lay the flap really well. And what I found early on is that I left a lot of junk in there. So I laid the flap, I cleaned it out well, and then I got better at it so that when I was laying flaps later on, I was confident that I had cleaned everything out. Where I thought I needed to go further, I knew if I needed to clean out more or not. Once you do it enough times, you won't need to lay flaps anymore. But once a flap is laid, easier to put your membrane on top of the between the bone and the periosteum, and then cover it back over. That's easier. If you're not laying a flap, then you put it in the socket. And the difference of that will be is the thickness of the bone itself, but I'm usually packing enough bone material inside of the membrane so the membrane is being pushed out. So let's say, just for visualization's sake on a webcam, here is my, and I just got, there we go. Here is my dehiscence, right? Here's my buccal plate. Here's my socket, my thumb on this side. Okay, so if I laid a flap, I'm putting the membrane here, right over on top of it. If I did not lay a flap, I'm putting the membrane here, but I'm putting enough graft inside the socket that it's kind of pushing its way out, right? So it's going to push its way out, and I'm going to feel that, so give myself a little bit more volume. I don't want to push it out. So that's the difference. But great question. Dr. Gelman again is the example of the premolar with the buccal defect. Is the buccal aspect of the membrane placed between the periosteum? Okay, great. We just answered that question again. Good question. Cole Smith asks, commenting on leaving the resorbable membrane exposed in case. What I understand is the impression that you should use a membrane like PTFE because you're not getting primary closure. No, just the opposite. A PTFE would need primary closure, which I can't get, or I don't want to get with a socket for a number of reasons. So, and again, I think this is the same point we're talked about a lot. but really important point to understand. Can you overfill the graft? Yes, if you can't close it well and it's too much, it's like just bursting at the seams, then yeah, it's too much. So you want it to be a little more than you need, but not so much that it's totally overflowing. David asks, I noticed you left the collagen membrane open in one of the grafting photos. Did I understand correctly? I thought you used the non-resorbable type like cytoplast. No worries on it resorbing too quickly because it's exposed in the mouth. So again, resorbable can be left exposed, non-resorbable needs primary closure. Dr. Gan asks, do you suture through or on top of the collagen plug? Right through it, because I want the suture to hold onto it. Sometimes I'll suture on top of it if it'll hold down well, just because there's enough overabundance of tissue on top. But usually I'll want to throw the suture through it to hold it into place. But you'll have to have an instrument pushing down on the material. Otherwise, when you throw the suture, it'll pull it right out. So push down on the plug while you're throwing sutures through it. Either you or your assistant. Dr. Karen asks, why do you prefer socket shield technique in that case to case number 3? Case number 3, I think, was the last one where I laid the flap, so it's just an early case. And socket shield, we talked about socket shield a little bit last time. I haven't done one myself. I probably will within this calendar year. So I'll have more to comment then. Dr. Griffin asks, are you placing your membranes between the bone? That we already talked about. Dr. Mogadasian, a co-resident of mine. Ben, how are you, man? It's been a long time. Where do you buy the diabetic syringe from? Any medical supplier. You can get it in a drugstore, I believe, anywhere. It's overly abundant. I don't believe the diabetic syringes are autoclavable, but a lot of companies will sell plastic syringes that are autoclavable. So it's just a matter of what you want to use. The autoclave, it has a life of a couple of cycles through it, because the rubber plunger, after you're going through a few cycles, just tends to get worn out, and when you'll try and pull it back, it'll just tear. So that's when you know you toss it. So diabetic syringes are nice that they're just one-time use and toss it out. So you can get it, I believe, in any drugstore. David asks, one more question, please. Any questions? We got plenty, nowhere to go. I have heard some say that even when we have buccal dehiscence, but the periosteum is intact, they don't use membrane, saying the periosteum is the best membrane. Great question. So the answer is yes. The periosteum is a membrane itself. What that means is when there's periosteum intact, the soft tissue will not grow through the periosteum into the bone. The periosteum itself holds everything back. So that's true. But once you've had pathology there, there's no periosteum. So if the bacteria has burrowed a hole through your bone, then you have no periosteum there. It's angry tissue. So that's just granulomatous tissue there that's left over, but it's not periosteum. So don't rely on that per se. Let's say hypothetically I take out a tooth, but I crack the buccal plate off, right? The tooth was taking it out because it had some other issue. Let's say, fracture at the gum line, so that the root is intact, but I cracked it trying to take it out. So then your periosteum is intact. So then yes, that periosteum could serve as a membrane, and you don't necessarily need another collagen membrane. But practically speaking, that periosteum will tend to just droop down into there. You're not going to get soft tissue infiltration the same way, but it'll kind of droop down. So I still want to push it back as much as I can. And I will kind of put the membrane there as an extra, belt and suspenders sort of situation, where I just get as much support as I possibly can. But in a case like that, could the periosteum hypothetically work? Then yes, it could, and good question. But again, in my situation, I'm just putting as much support as I can to make this work to the highest degree of predictability possible. Dr. Gen asks, do you save the remainder of the membrane for the next patient if it's cut out without contamination? So same answer to the bone grafting. The answer is yes, when done in a sterile field with sterile instruments, and then transferred the part that I need over and leave everything up behind. What do you think about BioAS pen? I think that's the one that comes in the pre-made syringe. We talked about that already. Pre-made syringes are a great convenience, but you're paying for the convenience. Dr. Zafir asks, say I have a defect on number 30 and I'll be placing a membrane. Does it matter if the membrane will be on the outside defect wall between the soft tissue or I place it into the socket? Good, we talked about that at length. Gabor asks, so are you saying that when the buccal plate is gone, you would not lay a flap to tuck in the membrane, you would place the membrane inside the socket? Yes. Jacob asks, how long does your membrane dissolve? It depends on the membrane. The one I use is, the most common one I use is from AGD Surgical. It's called RCM6, Removable Collagen Membrane. The 6 stands for 6 months. It'll dissolve in approximately 6 months when under the tissue. Okay, I got to thank you. You're welcome. Dr. Wang asked, thoughts of anion, chlorion, or bio-exclude membrane? Yes, bio-exclude is a nice material. I've used it many times, but it's expensive, and the properties, again, all these things that claim to have better osteoinductive properties and things like that, they really, really worked. Everyone will be using them. They have studies showing that. So it's a nice material. It kind of looks like saran wrap. It's like a really thin material. But it works well as a membrane, and it's a nice material. I actually really like it if I have a sinus tear. I like that because it kind of like, when it gets wet, it kind of gets gelatinous. So if I am doing a lateral lift and I have a sinus tear, it kind of just like sticks onto that tear and kind of closes it up if I use a big enough piece. So yes, it's a good material. I don't use it very often though, I found the expense not justifying the cost. And what I like about the RCM material, and again, this is just my personal preference, is it has some body to it. They make a few other material, ACE and makes a few other materials that are, again, a little bit more floppy, that when you get them wet, they turn into wet noodles. This one has a little bit more body to it, so I can manipulate it when it gets wet, and I prefer that in most situations. Thank you, and you're welcome, from Dr. Marr. I missed part 1, and how can I take it? I believe it's on the Blue Sky website. It's also on YouTube, and there's a test associated with it, so you can still get your credit for it. Mac Jones, that's a great name, asks, are you hydrating your allografts or placing it dry? Great question. I don't think I talked about this. Okay, so I am hydrating it. What you do is you take any kind of sterile liquid. So that could be, what I usually use is saline from the line I'm running on my implant handpiece, and I will overhydrate it with water in that little dish. Then I will take a piece of gauze, and it's sterile gauze. I sterilize gauze in little packs, and I use that for all surgical cases. I will take that and I will touch it to the end, and just a corner of the gauze just barely touching the water. What happens is it wicks out all the additional water, and it leaves me with a perfectly hydrated graft. It's very simple to do. It takes 10 seconds, and you get a perfectly hydrated graft. Then I will load it into the syringe. Much easier to handle when it's wet than when it's dry. Great question, and I apologize for not going over that earlier. Daniel Stern asks, what's your opinion for AUGMA? Talked about it. Dustin says, how are you getting primary closure on cases with buccal defects if you don't lay a flap, for example, in the anterior? So, as we talked about, I don't need primary closure in those cases. When everything else is in good shape, I don't need it. But if I need so much bone added that I'm going to need to close this up all the way, then I need to lay a flap to advance that flap and get primary closure. But a regular socket with a small defect, it's unnecessary. What did you mean by 1 millimeter bone when talking about grafting? 1 millimeter is referring to the wall of bone remaining. If it's 1 millimeter or more of bone remaining, the literature says that you don't necessarily need a graft, but as I talked about, it's still advantageous. Dr. Sherwood asks, just to clarify, when you place a membrane, are you placing the membrane? Okay, I think we get that question a number of times. We're placing it in the socket or between the periosteum. Okay. Dr. Springs asks, MIS sells a less expensive xenograft, as well as some useful calcium sulfate private labeled from Ogma. Okay, so same material, MIS is selling, doing the same idea. I believe both those companies are manufactured in Israel, so yeah, I guess that they may have collaborated on something. Good. Do you mix Xenograft with Allografts, and Xenograft is more stable? So what I'll do is I'll what they call a sandwich technique. I will use a Xenograft as my most exterior layer. I'll put my layer that's deeper inside, which is where my implant will go. I will put Allograft and then Xenograft layered on top of that. Dr. Brookshire asks, what is your opinion of Ogma's bone appetite? We talked about it. And when I get lots of those questions, just a shout out to Ogma. You guys are doing a fantastic job marketing because people are asking about it. So yeah, I would say that. But again, as I said before, I have never used it, and I don't love what it looks like on a CT scan, but I do like what it looks like on the clinically. I'm questioning the vascularity of that graft. Dr. Gann asks, is it okay to have a membrane in the buccal bone defect area, not fold over the socket, and use the collagen plug? Yeah, absolutely. What he's saying is, if I have, again, this defect here, buccal plate, lingual plate, I just put the membrane inside of here, and then I put a collagen on top of that, and the only membrane is just tucked in under the buccal plate. Yes, you could do that. I just find leaving it longer and tucking it on both sides is more stable. That's just what I find. But if you could stabilize it with just that one piece, that's totally fine also. Todd Adams asks, did you say that you put buccal or facial side of resorbable membrane in the socket versus between the buccal plate and soft tissue? Yeah, that's what we talked about already, about laying a flap or not laying a flap. Did you ever use non-resorbable membranes such as Cytoplast TXT, which is EPAT, and remove them 3 to 4 weeks? Yes, I have used it, and I do use it when I'm doing large vertical grafts. If I'm using titanium mesh, I will use that and then put the mesh usually underneath it and put the membrane on top of that. That's what I'll generally do. Yes, and it's a Cytoplast TXT. It's a good material and works well, and it has the titanium, has kind of a titanium mesh inside of it. So I oftentimes will get away with not using a separate mesh, just use that material alone because it has a piece of titanium inside of it that's bendable. That's a good material, but it's very expensive, but it's a really good material. Again, if you're using that for a socket, it's total overkill and not necessary, but it's a good material for what it's used for. For sinus lifts, do you use BioOS only or mixed with allograft? So again, everything will work. But the larger the sinus graft I need to do, the more I would want something more stable. So if I'm doing a large lateral lift, I would want some more stability to it. So I'll probably just use in those cases a larger amount of Xenograft than anything else. But again, they'll all work. Cytoplast by Autogenous we just talked about. Alexandra asked, do you always use antibiotics when you bone graft or not? We talked about that. Have you heard of SMART technique? Xenografts with BMP? I have not. So again, if you could shoot me an email with that details, I'm happy to look into it. George asks, I know you make gut sutures. Do you find this stays intact long enough for the tissue to stabilize? So good question, not always. Chromic gut suture is my go-to material. I mentioned last time, soak it in water for about 2 minutes and it throws really easily. Stays there for about 7 days. In most cases, for a socket, that's all you need. If I'm doing a bigger graft, I'm using either a Vicryl type of suture or a Teflon or a nylon or something that's a non-resorbable suture that I know will stay there for as long as I need it to be and come back at 4 to 6 weeks and remove that suture then. So I would say in your bread and butter cases, the chromic gut is what you'll need in most cases. In the bigger cases, when advancing flaps and things like that, you need things to stay there much longer than use a Vicryl or non-resorbable at all. Vilma asks, if you use the membrane, do you have to use fixation tacks or pins? No, you need it to stabilize. So if you use it, the technique I showed here, which I'm stabilizing it on the lingual and the buccal, that's usually enough. I'm not using tacks on those. I use tacks in big cases where I have to, over a large defect, to really hold it down. Kirsten makes a really nice product called Osteowrap for buccal walls, defect grafting. Okay, if you don't mind shooting me an email, I'd love to see that also. I just can't cut and paste these, and just going through the questions, I don't have time to write it down. So you could shoot me an email, I'd appreciate it. Osteowrap, I'll take a look at it. The great Stephen Lee asks, when a patient comes back for follow-up and resorbable membrane is no longer there, but particularly bone is visible and loose, what do you do? Is no longer there, particular bone is visible and loose, what do you do? So I would, anything that's visible and loose at a, again, when's the follow-up happening? If it's happening a week, leave it be, it's still too early. It's happening in a month, then what's happening, the inside should have more or less solidified, and we should have already keratinized mucosa on the outside, so it should be pretty firm already. So anything that's loose, and sometimes you'll see those little particles like in the soft tissue, and it's like kind of migrating its way out. Sometimes those excess pieces will just like push through the tissue. So if I see them, I'll pluck individual pieces off just so they don't annoy the patient. But you could leave them alone, they'll just slough off themselves. Vilma asks, what kind of suture do you recommend? Talked about that. Dr. Springs asks, is it true that some BMP is released when bone is demineralized, but it's also released when osteoclasts break it down? So the advertisements of osteoinduction are fairly meaningless. So again, I think the all the BMP is a growth factor. So yeah, the body does release it, absolutely. It's not that it's meaningless, it's just that it kind of gives it an extra boost. There's more of it. So there's what to be said about it, and in big graft cases, I find it to be somewhat helpful. But again, it's not critical because then you'd see it used in every graft. George asks, when curating the socket out of the maxillary molars, how do you differentiate between the granulation tissue and the flow of the sinus? Great question. So one is know your anatomy and know the socket that you just, the root you just hooked out. I will measure, if I don't have a CT in advance, because I didn't necessarily need one before, I'll wait to take my CT before I'm putting my implant in. I'm fairly certain I'm not going to put in the implant. I'm not going to take a pre-op CT in every case. Sometimes diagnostically I will need to, but again, assuming I don't have a CT, I'll just take the root and measure it and see where the end of the socket is. That will let me know where the end of the socket was. Now, if I saw radiographically that infection was already pouring into the sinus, so then I already have an oral enteral communication before I even started. And if those are the case, what I'll do is I don't want to pack particulate material in there because that particulate would get lost in the sinus and could create a mess in there. First of all, and as an aside, in those cases, make sure you're using if there's a chance of that happening, or if you're doing sinus grafting, make sure you're using a really small particle. Because we'll talk about in the sinus grafting course, sinus drains out of the ostium. The ostium is all the way up here, and it's a very narrow passageway. So if you have a material that is large, and the cilia of the sinus is trying to push out this material, and it pushes it into the ostium, and it gets stuck there, now you've created a full blockage of the sinus, and you've got a big problem. So anytime you have anything that has any chance of going into the sinus, it better be small. So use the 250 to 1,000 micron, not the 1,000 to 2,000 micron materials, because those will be big enough to clog something up. Okay, that's one. Two is if I'm using anything there, that might be a good time to use a foundation material because it's going to go into the sinus anyway. I may as well have something that's just going to dissolve, hold my space, and have no chance of getting lost in the sinus. So that's a good indication for use of foundation. Other times when it's a really small opening, and I can sometimes see it, it's the end of the root is already into the sinus, and sometimes you look at an x-ray, already preoperatively, the root is in the sinus. So you take out the root, you already have a communication. If that's small, I'll take a small piece of collagen, pack that in to seal it, and then I'll put in particulate material on top of that. So that's it. But I think you're asking more specifically when you're curating out, how do you make sure you don't go in the sinus? So you again, tread lightly. If it's not a big PAP, you just want to be gentle with it. And sometimes it'll happen. I'll be scraping out and then it kind of falls in. And if that happens, I know I create a small opening the size of the spoon I'm using. And I'll close that up with, again, a collagen something to seal it, and then treat it as a communication that way. So it could happen, and it will happen if you do enough of these, but just tread lightly. Not a great answer in terms of giving you something definitive, but just use your own judgment and don't press too hard. But if you do press too hard, you've made a small opening and it's easily repairable. Again, by not even doing anything per se, just by closing it with a socket and giving them post-op sinus instructions. And then again, we'll talk about more of that in the sinus lecture. Dr. Hassan asked, you don't have to read this question. Okay. I emailed you about sorcery and ethos. Thank you. Dr. Zafir S said, when do you prescribe Paradex? Do you wait a week before taking it, and how long do they use it, the Paradex rinse? So I will tell you of what in my standard post-ops, and this is not because Paradex is a magic sorcery potion. When I prescribe Paradex, and I do, I am giving them prescription to clean the surgical site. What I found is if you don't do that and you tell them to be gentle when they brush, they just say, well, I'm just not going to brush it. And they'll come back after a post-op, and let's say you saw them for a week and then you didn't see them again until 3 months later. They will not have brushed that area or the tooth next to it for 3 months. So what I do is I tell them, you have a prescription to clean the area. I'm going to show you how to do it without causing damage to it. And what I do is I tell them, don't rinse with it, because I don't want them rinsing and dislodging the grafts from the socket. I tell them, put some of the material on a piece of gauze, and I give them gauze to take home, and wipe the socket or the site with Paradex twice a day after you brush everything else for, let's say, 2 weeks. That way I've given them prescription to clean the area, and then when the 2 weeks is over, they should be brushing with a toothbrush again. That being said, if I can assure myself that they'll clean it, then I don't really need the Paradex. They could use water and gauze also. But if I tell them water and gauze, that's like, oh, it's not a prescription, it's just something to do. Well, I don't have to do that. If it's a prescription material, I better put this magic potion on the tissue, or else it's not going to heal. So I just know that they're going to use it if I prescribe it. And another side benefit of using it on gauze rather than rinsing with it is if they use Paradex for any prolonged period of time, you'll find that it leaves a stain on all the teeth that you need to use like a Cavitron to remove it. So since nobody likes that, we don't prescribe Paradex to rinse, just to use on a gauze. In Europe, you could buy Paradex over the counter because it's a helpful material, but it stains the teeth brown. In America, Americans don't like brown teeth, so you have to get a prescription. But in Europe, you know what they say about British teeth. I don't mean to offend any British dentist store here, but you know what I'm saying. They don't mind as much, so you can buy it over the counter. Scott asks, have you ever used Ogma? Talked about it. Ben, nice to see you too. Ariel says, how do we take the quiz for CE? So Michael clarified, that's only if you are not watching it live. If you watch it live, you got credit anyway. Reza asks, when you're removing titanium mesh and you missed a tack, do you go back looking for it or leave it alone? Good question. So when we are using tacks, and again, tacks are much more advanced, I don't necessarily remove it. I have to make a much bigger flap to get to it. If everything's healed well and everything's stable, and I use a resorbable membrane, and it's totally dissolved, the tack can sit there forever. It's not going to bother anybody. Okay, suture removal when everything is stable, or if you're using a material that needs to be cut out earlier, then when that material needs to be cut out earlier. So if it's silk, it needs to be cut out in a week, or else it's going to wick a lot of bacteria. Other materials, nylon can sit there for much longer. Teflon can sit there for also much longer. So I wait for things to heal up, and then I remove it. Do you prescribe Paradex? We talked about that. Ramzan asked, the resorbable membrane exposed and dissolving. Does the bone graft not get infected with food and bacteria in the mouth? Question mark, question mark, question mark. No, it doesn't, because things don't tend to get infected in the mouth well. And by the time it dissolves in 2 or 3 days, the clot's already stable and sealed. I thought, hence the reason non-resorbable membranes. So that's, I understand the thought process, but that's not actually correct. I was under the impression that resorbable membrane needs primary closure. We talked about that in great detail already. After socket preservation, you place the implant at 6 months in the maxilla. It's for the next lecture, but I'll just mention briefly my standard numbers that I use for time is maxilla 4 months after the socket graft, and mandible 3 months, just because the density of the bone, I need things that firm up a little bit more in the maxilla. Denise asks, what do you think of osteogen plugs? We talked about that. Reza asks, we have 9 more questions left here. Is chlorhexidine better over saline to flush socket before graft? So I don't, again, it's just a matter of clearing it out. The flush afterwards is really unimportant. I talked about last time, I'm using overwhelming majority is the water from the line to clean things out along with the handpiece, because it's the physical removal and debriding of the tissue there than it is rinsing anything per se. So chlorhexidine is not necessary. You can use sterile water also to flush it out with a monojet. That'll work. Chlorhexidine will work fine also. I believe there's a study on rinsing with chlorhexidine that it slows healing, but I don't think clinically it makes a really big difference. So whatever you like to use is fine. Mohammed asks again, if you, after resorption of exposed part of the membrane, the graft material could fall out of the socket. I understand your angst here with the exclamation point and question mark after the question. As we talked about, by the time that dissolves, what will be left with is a stable clot. The stable clot is not going anywhere. And I promise you, I've done a lot of these. They stay in the mouth. What about only detaching the periosteum on the buccal without any releasing incision and slide the membrane between the bone and the periosteum, so we can bulk out the buccal graft in the volume instead of an ice cream cone technique? So I hear you saying, Vlad, and that's a good idea. But as we said, when you remove the periosteum, you've decreased the soft tissue. I mean, I'm sorry, you've cut off the blood supply to that buccal wall. So there's a big loss in doing that, even without a releasing incision. Releasing incision is actually not as important as is the flap itself. So it's an envelope flap, as they call it, without a release. You could tuck your membrane, but you're going to lose oxygen to that bone in between. So ill-advised if otherwise avoidable. Say not the ideal situation. You could still do it, and will it make a clinical difference? That's all a bigger argument. And if you have a bigger defect that you need to graft, as we said before, you could leave that be. But whenever possible, don't remove the periosteum from the bone. Are you planning soft tissue course soon? We don't have one planned here. I think we'll if you can make requests, send in some requests, either email me or I'll put my email address back up here. Put this away. Email me or Michael. And put requests for what lectures you want to do next. We're going to do the simple implant surgery, just a single implant surgery next. But put whatever requests you want in, and we're happy to put whatever you like up. We have as much time as we are out of work, so we will be doing hopefully not too many more courses, but probably several more courses. Cytoplast is used and successful when not primary closed. I think that's a statement more than the question. Yeah, cytoplast is a good material. I generally try and get primary closure over it whenever I can, but I know people will say that they don't get primary closure always, and it doesn't wick bacteria like some of the older EPAT materials did. Do you prescribe Paradex rinse? We talked about that. What about Dermabond adhesive? I don't know what that is, so I'll leave that alone. If you want to email me that term, I will look into it and get back to you with an opinion about just what the science is without any clinical basis. Dr. Hannah asked difference combinations, cortical cancellous, mineralized, demineralized, which combination do you prefer and why? We talked about that during the lecture, but in very short, demineralized will not show up in an x-ray while it's there until the new bone heals around it and mineralizes. I don't like that, but some do. Cortical cancellous, I like to do a mix, and that's why. No, the why is because it's the best of the harder material versus the softer material for overall healing. Dustin asks, still not clear on when you need primary closure versus when you do not, and why you need primary closure versus for a non-resorbable membrane. So again, we'll just say this again because it's an important point, and I think a lot of people miss this. We talked about the socket and the scab idea. So the scab shows you, the scab on your arm that you picked off too early shows you that epithelium grows only from the sides. So I don't need primary closure where I don't have a connective tissue yet formed underneath. So while it heals from the sides, I don't need primary closure in the socket. So I'll say that. It's an important takeaway. You do not need primary closure for a regular plain socket. When the wall is completely missing and you have a membrane that you need that membrane to stay there, I want to completely cover over in those cases. If you already put a membrane into a socket, you can get primary closure. It's not going to hurt you in terms of closing it over because the tissue is not going to grow down. But I don't do that because when I advance the flap, what I'm bringing is my mucosal, the line between the attached tissue and the unattached tissue, down much further than it should be, and I'll have to correct that later to have proper attached tissue around the implant, which we'll talk about in great detail at the next lecture. But again, really important point. If people would like, shoot me an email. I may make a separate video just to upload to talk about this concept and maybe with some graphics to make it clearer. So if you're still unclear, if my explanations were still not good enough, please shoot me an email and we'll maybe put something out there. Thank you for the lecture. Thank you for the lecture. You're welcome. You're welcome. And Ariel asks, the last and final question of the evening, or the morning or the afternoon, wherever time zone you're in, how do you, have you used the Osteogen plugs? We talked about that and we're done. Any more questions? Shoot. I think we're good. Thank you to the 161 people who have stuck around to the end of the three. Our high point was 300 something, so we got to. Hope we helped out with a lot of the concepts of grafting and a lot of basic misnomers. I hope we cleared up. And yeah, if you're not grafting yet already and something you're looking to get into, certainly encourage you to do that. And feel free to send me pre-op, post-op stuff, and I'm happy to comment and offer my suggestions for future improvement.
Okay, we have a lineup coming up over the next few days that includes tomorrow. Again, we have the pleasure of hearing from Dr. Robert Mickley, and then in the next few days we have a lineup including Dr. Russell Schaefer, Dr. Raymond Rofi, Dr. Rick Ferguson, Dr. Baron Brother, Dr. David Vige, and many more. So check out, again, the websites and Facebook groups, stay up to date regarding upcoming webinars. Everything's being recorded again, so if you're missing anything, you can watch the recording, take the 10-question multiple choice test, and then get the CE. If you're watching live, then you don't need to take the quiz. You'll be sent the CE credits within around 2 weeks. So check your email, be patient, and it will get to you. Robert, again, thank you so much for stage 2, part 2 of the webinar series. Look forward to tomorrow and future webinars. And thank you everybody for attending. Stay safe, stay healthy, take care of yourselves. And I think that's a wrap.
All right, also I just want to say, from a lecturer point of view, when I teach classes and I have groups of people, there's a lot of positive feedback just by seeing people. Here in these forums, I'm looking at myself on a screen. I'm seeing the questions rolling in, which are helpful. But if anyone also would like to get into like a smaller group chat for some of these things, I'm happy to do that also. Just shoot me an email. We'll put together a Zoom group and make that happen.
Yeah, definitely. You should take advantage of the in-office training that Dr. Robert Mickley has to offer.
All right, everybody.
Definitely.
Have a great rest of your day.
Thank you.
My course description was not covered. Somebody just said, what did I not cover?
1 second, I think we're still live, just
Yeah.
so you know.
Somebody just said my course description was not covered. Exclamation point, exclamation point. What, could you clarify? What, I think we said this was, what we did last time was we covered the atraumatic extraction last video. So if you missed that course, please jump back in there. This was the bone grafting section. We just got a little bit ahead of ourselves last time and got into the atraumatic extraction. And this time we did just the grafting. So go back to the last video and you should get everything covered.
Thank you. Thank you for clarifying that.